Neurology and Special Senses audiobook for USMLE Step 1. Starting with neurology, embryology. Neural development begins with the formation of the neural plate, then progresses into the neural fold, and soon involves the neural crest cells and the neural tube. At the heart of this neural plate lies the notochord, and the notochord, which later becomes the nucleus pulposus of the intervertebral discs, plays a crucial role by inducing the overlying ectoderm to form neuroectoderm, which then becomes the neural plate. This neural plate, under the influence of signaling molecules and genetic regulation, gives rise to both the neural tube and the neural crest cells, setting the stage for complex nervous system development. Now let's talk about the next phase, where the lateral walls of the neural tube are divided into two key regions, the alar plate and the basal plate. The alar plate, which lies dorsally, is responsible for sensory functions, and its formation is induced by bone morphogenetic proteins, or BMPs, while its orientation matches that of the spinal cord. On the other hand, the basal plate, which lies ventrally, is responsible for motor functions, and its development is induced by the sonic hedgehog protein, often abbreviated as SHH. And you should remember this, homeobox genes, or HOX genes, are crucial for regulating neural tube segmentation and cranial to caudal differentiation, while mutations in these genes can lead to abnormalities like syndactyly in limbs and hypospadias in the urogenital system. Let's enter the realm of regionalization of the neural tube, where the very first structure to form is the telencephalon, followed by the diencephalon, and then, in alphabetical order, come the mesencephalon, metencephalon, and myelencephalon. The three primary brain vesicles, which are the forebrain, or prosencephalon, the midbrain, or mesencephalon, and the hindbrain, or rhombencephalon, give rise to 5 secondary vesicles, and these eventually mature into the structures of the adult brain. So, let's explore this transformation step by step to understand how these vesicles become the components of the central nervous system. Now listen carefully, from the walls of the telencephalon arise the cerebral hemispheres and basal ganglia, while the diencephalon forms the thalamus and hypothalamus. The midbrain remains the mesencephalon, and gives rise to the adult midbrain, while the metencephalon becomes both the pons and the cerebellum, and the myelencephalon transforms into the medulla. The spinal cord also emerges from the continuation of the neural tube, completing the central axis of the nervous system, and these structures are paired with corresponding cavities which serve as the ventricles of the brain and the central canal of the spinal cord. You should remember this, the adult derivatives of these secondary vesicles form distinct brain cavities, so the telencephalon gives rise to the lateral ventricles, the diencephalon to the third ventricle, the mesencephalon to the cerebral aqueduct, while the upper part of the fourth ventricle arises from the metencephalon, and the lower part from the myelencephalon. These cavities hold cerebrospinal fluid and support the brain's internal architecture, while also connecting various parts of the central nervous system, and any disruption in their formation can lead to congenital anomalies like hydrocephalus. And now, let's turn our attention to the origins of the central and peripheral nervous systems. From the neuroepithelia in the neural tube arise the CNS neurons, and the glial cells of the central nervous system, which include astrocytes, oligodendrocytes, and the ependymal cells. From the neural crest, emerge the neurons of the peripheral nervous system, including the dorsal root ganglia, and the autonomic ganglia, whether sympathetic, parasympathetic, or enteric, as well as the glial cells of the PNS, such as Schwann cells and satellite cells, also they give rise adrenal medulla. Lastly, from the mesoderm, we get the microglia, which are specialized macrophages that function within the central nervous system, completing the story of how various germ layers contribute to neural structures. Neural tube defects occur when the neural tube fails to close completely by the 4th week of development, and this serious complication is associated with maternal folate deficiency, or exposure to teratogenic medications, such as valproate and carbamazepine, during pregnancy. These defects are typically diagnosed through prenatal ultrasound, as well as maternal serum alpha-fetoprotein, or AFP, and sometimes amniotic fluid acetylcholinesterase, abbreviated ACHE, particularly in cases of open neural tube defects. You should remember this, these conditions can lead to a range of spinal and cranial abnormalities, depending on the site and extent of closure failure. Now let's talk about spinal dysraphism, which includes several types of neural tube defects affecting the spinal region. Spina bifida occulta is a closed neural tube defect, where the caudal neural tube fails to close, but crucially, there is no herniation and the dura remains intact. It is usually observed at the lower vertebral levels and may be marked by a tuft of hair or a skin dimple at the site of the underlying bony defect. Then comes meningocele, an open neural tube defect where the meninges, but not the neural tissue, herniate through a defect in the bone. In contrast, myelomeningocele is also an open neural tube defect, but in this case, both the meninges and neural tissue, such as the cauda equina, herniate through the defect. Listen carefully, another severe type of defect is myeloschisis, an open neural tube defect characterized by exposed, unfused neural tissue, which lacks any covering by skin or meninges. Now we're shifting to cranial dysraphism, starting with anencephaly, which is an open neural tube defect resulting from failure of the rostral neuropore to close, leading to absence of the forebrain and an open calvarium. This condition often presents with polyhydramnios due to impaired fetal swallowing, since neural control mechanisms are absent. Now let's turn our attention to holoprosencephaly, a severe brain malformation caused by failure of the forebrain, or prosencephalon, to divide into two cerebral hemispheres. This developmental field defect typically occurs during weeks 3 to 4 of embryogenesis and is frequently associated with mutations in the sonic hedgehog, or SHH gene. It can also be seen in syndromes such as Patau syndrome, which is trisomy 13, and fetal alcohol syndrome. Clinical presentation includes midline facial defects such as a monoventricle, fused basal ganglia, cleft lip or cleft palate, hypotelorism, cyclopia, or a single midline eye, and even a proboscis. These children also have an increased risk for pituitary dysfunctions, like diabetes insipidus. And now, listen carefully, because lissencephaly is another brain abnormality, caused by failure of neuronal migration, which leads to a smooth brain surface that lacks the usual sulci and gyri. This condition presents with symptoms like dysphagia, difficulty in swallowing, seizures that can be frequent and difficult to control, microcephaly, where the head is smaller than normal, and facial anomalies. When we talk about posterior fossa malformations, we begin with Chiari-1 malformation, which is defined as the downward displacement of the cerebellar tonsils through the foramen magnum. Just one structure is involved here. This condition is often asymptomatic during childhood, but it tends to manifest later in adulthood with headaches and cerebellar symptoms like imbalance or coordination difficulties. Importantly, Chiari-1 is associated with spinal cord cavitations, particularly syringomyelia, which can further complicate the clinical picture. Talking about Chiari-2 malformation, which is more severe and involves downward displacement of both the cerebellum, specifically the vermis and tonsils, and the medulla, making it a two-structure involvement. This displacement through the foramen magnum leads to non-communicating hydrocephalus due to obstruction of cerebrospinal fluid flow. Typically presenting early in life, Chiari-2 can cause dysphagia, stridor, apnea, and limb weakness, and it is often associated with a lumbosacral myelomeningocele, adding another layer of neurological involvement. Are you following me? Because now we're shifting to the Dandy-Walker malformation, which involves agenesis of the cerebellar vermis and results in cystic enlargement of the fourth ventricle, which fills an enlarged posterior fossa. This malformation is associated with non-communicating hydrocephalus and often occurs alongside spina bifida. The posterior fossa appears significantly dilated, and the absence of the vermis disrupts normal cerebrospinal fluid flow, which can lead to increased intracranial pressure and developmental delays. Syringomyelia is a condition characterized by a fluid-filled, gliosis-lined cavity within the spinal cord. This is the syrinx, from the Greek word for tube, as in syringe. These cavities most commonly develop between spinal levels C2 and T9, and they typically damage the fibers crossing in the anterior white commissure, particularly those of the spinothalamic tract. This results in a characteristic, cape-like, loss of pain and temperature sensation across the bilateral upper extremities. You should remember this, because as the syrinx expands, it may also compress the anterior horns of the spinal cord, leading to lower motor neuron findings such as muscle weakness and atrophy. Most syringomyelia cases are associated with Chiari-1 malformation, but in some instances, they may be linked to other congenital malformations, infections, tumors, or trauma. The disruption in neural conduction can affect multiple dermatomes, making the symptoms diverse and progressive. Now let's focus on the C5 to T4 lesion example, where the syrinx compresses the anterior white commissure, leading to the selective loss of pain and temperature sensation across those dermatomes. The lateral spinothalamic tract, which carries pain and temperature, becomes disrupted, while dorsal columns, which carry fine touch and proprioception, are typically spared early on. The dorsal root ganglia remain intact, but the dermatomes affected show a distinct, bilateral pattern of sensory loss, often the first clue leading to diagnosis. Let's shift to neurology, anatomy and physiology. Talking about the cells of the nervous system, which include both neurons and non-neuronal, or glial, cells. Neurons are permanent, signal-transmitting cells of the nervous system, and they are composed of dendrites, which receive input, cell bodies, and axons, which send output. You should remember this: dendrites and cell bodies can be seen on Nissl staining, which stains the rough endoplasmic reticulum, while axons do not contain this and are not stained. Important markers for neurons include neurofilament protein and synaptophysin. The fucking glial cells of the central nervous system, or CNS, are derived from the neuroectoderm, except for microglia, which come from the mesoderm. On the other hand, the glial cells of the peripheral nervous system, or PNS, come from the neural crest ectoderm. Myelin is a multilayer wrapping of electrical insulation that is formed around axons, and it increases the conduction velocity of transmitted signals by enabling saltatory conduction of action potentials at the nodes of Ranvier, which have a high density of sodium channels. Are you following me? Let's move on to the CNS glial cells. Astrocytes provide physical support, assist in repair, help remove excess neurotransmitters, contribute to the blood-brain barrier, and act as a glycogen fuel reserve buffer. They are GFAP positive, and they are the largest and most abundant glial cell in the CNS. In response to neural injury, they undergo reactive gliosis, which is a key feature of their function in pathology. Let's discuss oligodendrocytes, which myelinate axons in the CNS, including cranial nerve 2. Histologically, they have a fried egg appearance, and you might think of them as oligodendrocytes. Each one myelinates many axons, about 30 of them, and they are the predominant type of glial cell in white matter. These cells are injured in conditions such as multiple sclerosis, leukodystrophies, and progressive multifocal leukoencephalopathy. Ependymal cells are ciliated, simple columnar glial cells that line the ventricles and the central canal of the spinal cord. Their apical surfaces are covered with cilia, which circulate cerebrospinal fluid, and microvilli, which help with cerebrospinal fluid absorption. Specialized ependymal cells, known as the choroid plexus, are responsible for producing cerebrospinal fluid, a vital function in maintaining central nervous system homeostasis. Are you ready for more? Microglia are activated in response to tissue damage and release inflammatory mediators such as nitric oxide and glutamate. They are not readily discernible by Nissl stain, but they are phagocytic scavenger cells of the central nervous system. In HIV-associated dementia, HIV-infected microglia can fuse to form multinucleated giant cells, which is a distinctive pathological feature you should remember. Finally, let's explore the glial cells of the peripheral nervous system. Satellite cells surround neuronal cell bodies and ganglia, and they play a supportive role similar to that of astrocytes in the CNS. And Schwann cells myelinate axons in the PNS, including cranial nerves 3 through 12. They are S100 positive, and each Schwann cell myelinates a single axon, which you can remember by thinking of them as Schwann cells. These cells are damaged in Guillain-Barré syndrome, an important clinical condition to be aware of. Now let's talk about the neuron action potential, which begins with the resting membrane potential. At rest, the membrane is more permeable to potassium than to sodium, and during this phase, voltage-gated sodium and potassium channels are closed. The resting potential sits around -70 mV, and at this stage, intracellular potassium is high, while sodium is more concentrated outside the cell. This balance maintains the electrical state of the neuron before stimulation begins. Are you ready to explore what happens next? During membrane depolarization, the sodium activation gate opens, allowing sodium ions to flow inward rapidly, moving the membrane potential toward a more positive value. This sudden inflow pushes the membrane potential upward, passing the threshold of -55 mV, and approaching a peak of about +40 mV. At this point, the sodium channel is now conducting, and the neuron is in its excited, firing state. Now listen carefully, because at the peak of this electrical surge, something critical happens: membrane repolarization. The sodium inactivation gate now closes, effectively stopping further sodium inflow. Simultaneously, the potassium activation gate opens, allowing potassium ions to flow outward. This outward movement of positive charge drives the membrane potential back down toward its resting state, completing the repolarization phase. Are you following me? There's still more. Membrane hyperpolarization follows because the potassium activation gates are slow to close. This slowness results in excess potassium efflux, leading to a brief period where the membrane potential becomes even more negative than the resting level, sometimes dipping below -75 mV. During this phase, the voltage-gated sodium channels begin to reset, switching back to their resting state, and the sodium-potassium pump helps restore the original ion concentrations. Now let's switch gears and explore the sensory receptors. Free nerve endings are first, and they include A delta fibers, which are fast and myelinated, and C fibers, which are slow and unmyelinated. You should remember this: a delta plane is fast, but a tach C is slow. These receptors are found in almost all tissues except cartilage and the eye lens, and they are especially numerous in the skin, where they sense pain and temperature changes. Are you ready to go deeper? Meissner corpuscles come next. They consist of large, myelinated fibers that adapt quickly, and they are located in glabrous, or hairless, skin like the palms, soles, and lips. These receptors detect dynamic sensations like fine or light touch, low-frequency vibration, and skin indentation, allowing us to perceive delicate surface details. Now listen carefully. Pacinian corpuscles are another important type, made of large, myelinated fibers that also adapt quickly. They are found in deep skin layers, ligaments, and joints, and they respond to high-frequency vibration and pressure, just like a pressure cooker. These receptors help us detect fast, strong mechanical changes deep beneath the surface of the skin. Are you following me? Merkel discs come next. These are made of large, myelinated fibers that adapt slowly, and they are located in the fingertips and superficial layers of skin. They are responsible for sensing pressure and deep static touch, such as the edges and shapes of objects we hold or feel. Their slow adaptation allows us to detect sustained tactile details. Finally, let's discuss Ruffini corpuscles, which are composed of large, myelinated fibers that are intertwined among collagen bundles, and they also adapt slowly. Found in the fingertips and joints, they respond to stretch and joint angle changes. Let's talk about the fucking peripheral nerve. The endoneurium is a thin, supportive connective tissue that ensheaths and supports individual myelinated nerve fibers, and it may be affected in Guillain-Barré syndrome. Next, the perineurium, which serves as the blood-nerve permeability barrier, surrounds a fascicle of nerve fibers and protects them from external substances. Finally, the epineurium is a dense connective tissue that surrounds the entire nerve, including both the fascicles and their accompanying blood vessels. Motherfuckers, are you following me? To help remember this, think of endo as inner, peri as around, and epi as outer. Diving into the neuronal response to axonal injury. Chromatolysis is one of the first signs, a dispersion of Nissl substance throughout the cytoplasm, meaning that the rough endoplasmic reticulum is no longer visible on staining. This is a reaction of the neuronal cell body reflecting increased protein synthesis in an effort to repair the damaged axon. It is usually accompanied by round cellular swelling and the displacement of the nucleus to the periphery of the cell body. Remember this next part clearly. Axonal retraction occurs when the proximal segment of the axon retracts and begins to sprout new protrusions, growing toward other neurons in an attempt at reinnervation. In the peripheral nervous system, Schwann cells play a guiding role, forming a track that leads the regenerating axon back to its target. This guidance is crucial for functional recovery after peripheral nerve injury. Wallerian degeneration is the next key process. It involves the disintegration of the distal axon segment along with its associated myelin sheath. Macrophages enter the area and remove the cellular debris. However, while this process facilitates regeneration in the peripheral nervous system, in the central nervous system, the persistence of myelin debris and the presence of reactive gliosis inhibit regeneration. So remember, effective regeneration is more likely in the PNS than in the CNS. Are you ready to move into something more biochemical? Let's talk about neurotransmitter changes with disease. For acetylcholine, which is synthesized in the basal nucleus of Maynard in the forebrain, levels are decreased in Alzheimer's disease and Huntington disease, but increased in Parkinson disease. That's a pattern worth keeping in mind. Now dopamine, which is made in the ventral tegmentum and substantia nigra compacta of the midbrain, is decreased in both depression and Parkinson disease, but elevated in schizophrenia and Huntington disease. You should remember this. GABA, synthesized in the nucleus accumbens of the basal ganglia, is decreased in both anxiety and Huntington disease. Moving on to norepinephrine, which is produced in the locus coeruleus of the pons, it is increased in anxiety, but decreased in depression. And finally, serotonin, synthesized in the raphe nuclei of the brainstem, is decreased in both anxiety and depression, highlighting its critical role in emotional regulation and mood balance. It is also decreased in Parkinson's disease. Let's talk about the meninges, which are three membranes that surround and protect the brain and spinal cord, and they are derived from both the neural crest and the mesoderm. The dura mater is the thick outer layer, and it lies closest to the skull. The arachnoid mater is the middle layer and it contains web-like connections. The pia mater is the thin, fibrous inner layer that firmly adheres to both the brain and the spinal cord. Now listen carefully. CSF flows in the subarachnoid space, which is the space located between the arachnoid and the pia mater. The epidural space is a potential space between the dura mater and the skull or vertebral column, and it contains fat and blood vessels. This space becomes clinically significant as it is the site of blood collection associated with injury to the middle meningeal artery. Additionally, you should remember the presence of bridging veins that pass through the meningeal layers, and these veins, along with the membranes, dura mater, arachnoid mater, and pia mater, help protect the brain while maintaining circulation within the cranial cavity. The blood-brain barrier. It prevents circulating blood substances, like bacteria or drugs, from reaching the cerebrospinal fluid and the central nervous system. This barrier is formed by four main structures. First, the tight junctions between non-fenestrated capillary endothelial cells, second, the basement membrane, third, the pericytes, and fourth, the astrocyte foot processes. These work together to maintain the brain's selective permeability and protect its internal environment. Glucose and amino acids cross the barrier slowly, and they do so by carrier-mediated transport mechanisms. On the other hand, nonpolar and lipid-soluble substances cross the barrier rapidly, and they do so via diffusion. There are certain areas called circumventricular organs, which have fenestrated capillaries and no blood-brain barrier, allowing molecules in the blood to affect brain function. For example, the area postrema causes vomiting after chemotherapy, and the OVLT, or organum vasculosum of the lamina terminalis, contains osmoreceptors. You should also remember this: some neurosecretory products can enter the circulation through these same regions, such as ADH release from the neurohypophysis. Disruption of the blood-brain barrier, as seen in stroke, can lead to vasogenic edema. Hyperosmolar agents like mannitol can also disrupt the barrier, which increases the permeability of medications, making them more accessible to the central nervous system during certain treatments. Have you heard about the vomiting center? This center is coordinated by the nucleus tractus solitarius, or NTS, in the medulla, which receives information from multiple sources. These include the chemoreceptor trigger zone, located within the area postrema at the base of the fourth ventricle, the gastrointestinal tract via the vagus nerve, the vestibular system, and the central nervous system. Each of these components sends input that ultimately influences nausea and vomiting reflexes. Are you ready for the details? The chemoreceptor trigger zone and the adjacent vomiting center nuclei receive input through 5 major receptors: histamine H1, muscarinic M1, neurokinin NK1, dopamine D2, and serotonin 5-HT3. Antagonists of 5-HT3, D2, and NK1 receptors are used to treat chemotherapy-induced vomiting. Meanwhile, H1 and M1 antagonists are effective for treating motion sickness, and H1 antagonists are also used to manage hyperemesis gravidarum. Now let's talk about sleep physiology. Sleep occurs in 4 to 6 cycles per night, and each cycle lasts about 90 minutes, consisting of 2 main stages: non-rapid eye movement sleep, also called NREM sleep, and rapid eye movement sleep, also called REM sleep. You should remember this: while the night progresses, the duration of REM sleep increases. And the sleep-wake cycle itself is regulated by the circadian rhythm, which originates in the suprachiasmatic nucleus, or SCN. Less exposure to light reduces SCN activity, which in turn increases norepinephrine release from the superior cervical ganglion, and this finally increases melatonin secretion from the pineal gland. Because EEG waveforms are crucial here. You'll encounter beta, alpha, theta, sleep spindle, delta, and beta again. At night, an easy way to remember them is the phrase, "bats drink blood." These waveforms correspond to different stages of wakefulness and sleep. When you're awake and alert with eyes open, the EEG shows beta waves, which have the highest frequency and lowest amplitude. When your eyes are closed, alpha waves take over. Then, as you enter NREM sleep, you go through a sequence, starting with stage N1 and moving into deeper stages. Are you following me? Let's break it down. Stage N1 makes up 5% of total sleep and is the lightest stage, showing theta waves on EEG. Stage N2, which accounts for 45% of sleep, is deeper, and it is characterized by sleep spindles and K complexes. This is the stage where bruxism, or tooth grinding, typically happens. Then comes stage N3, which is the deepest NREM sleep stage, also called slow-wave sleep, and it makes up 25% of total sleep. It shows delta waves, which have the lowest frequency and highest amplitude. This is the stage when bedwetting, sleepwalking, and night terrors commonly occur, so remember, we and flee in N3. Now let's move to REM sleep, which also comprises 25% of total sleep. In this stage, there's a loss of muscle tone, or atonia, except in the diaphragm and the extraocular muscles. Brain oxygen use increases, while pulse and blood pressure become variable. This is when dreaming happens, along with nightmares and penile or clitoral tumescence, and a helpful phrase to recall this is, remember dreams. There's also a condition known as REM sleep behavior disorder, which involves the loss of normal atonia, leading to dream enactment, often violent, and vocalization. It's most commonly associated with Lewy body dementia and Parkinson disease. Now let's talk about factors that affect sleep architecture. Alcohol, benzodiazepines, and barbiturates reduce both N3 and REM sleep, though benzodiazepines can be useful for managing sleepwalking and night terrors. Aging also reduces N3 and REM sleep, while increasing sleep onset latency and causing early morning awakenings. Depression leads to reduced N3 sleep, increased REM sleep, shortened REM latency, repeated nighttime awakenings, and something called terminal insomnia, which is waking up too early. Finally, in narcolepsy, the REM latency is reduced, which means patients enter REM sleep more quickly than normal. Let's talk about the hypothalamus. This vital region maintains homeostasis by regulating thirst and water balance, controlling the adenohypophysis, also called the anterior pituitary, and the neurohypophysis, which is the posterior pituitary, and by releasing hormones produced right in the hypothalamus. It also plays a major role in regulating hunger, the autonomic nervous system, temperature, and sexual urges. So remember the mnemonic, tan hats. As for its inputs, some areas are not protected by the blood-brain barrier, like the OVLT, which senses changes in osmolarity, and the area postrema, located in the dorsal medulla, which responds to emetic stimuli. Now listen carefully, because each nucleus in the hypothalamus has a distinct function. The lateral nucleus governs hunger, it's stimulated by ghrelin and inhibited by leptin. Injury to this nucleus makes you lean, so destruction can lead to anorexia and failure to thrive, especially in infants. On the other hand, the ventromedial nucleus is responsible for satiety, and it's stimulated by leptin. Injury here makes you very massive. For instance, destruction caused by a craniopharyngioma can lead to hyperphagia. The anterior nucleus controls cooling and uses parasympathetic pathways. Just remember, /C stands for anterior cooling. Are you following me? Because the posterior nucleus handles heating and uses the sympathetic system. A good way to remember that is to think, heating is controlled by the posterior nucleus, like a hot pot. Then comes the suprachiasmatic nucleus, which is your internal clock. It regulates the circadian rhythm, and a helpful phrase to recall this is SCN is a sun-sensing nucleus. Moving forward, the supraoptic and paraventricular nuclei synthesize ADH and oxytocin. Think of the mnemonic SAD POX, where supraoptic equals ADH, and paraventricular equals oxytocin. These hormones are carried by neurophocyns down axons to the posterior pituitary, where they are stored and later released. If this system is destroyed, it leads to central diabetes insipidus. Now let's talk about the preoptic nucleus. It's involved in thermoregulation and sexual behavior and is responsible for releasing GnRH. When GnRH-producing neurons fail to migrate from the olfactory pit, the result is Kallmann syndrome. Shifting now to the thalamus, this is the major relay station for all ascending sensory information, except for olfaction. That's important, every sense passes through it, except smell. Let's dive into the individual nuclei. The ventral posterolateral nucleus receives input from the spinothalamic tract and the dorsal columns or medial lemniscus. It processes vibration, pain, pressure, proprioception, light touch, and temperature, then sends that information to the primary somatosensory cortex in the parietal lobe. Now listen carefully again. The ventral posteromedial nucleus handles input from the trigeminal and gustatory pathways, and is responsible for face sensation and taste. It also projects to the primary somatosensory cortex in the parietal lobe. And a helpful phrase here is, very pretty makeup goes on the face. Then we have the lateral geniculate nucleus, which receives signals from cranial nerve 2, the optic chiasm, and the optic tract. This nucleus processes vision and sends it to the primary visual cortex in the occipital lobe. Remember this, lateral means light. The medial geniculate nucleus gets input from the superior olive and the inferior colliculus of the tectum. It processes hearing and sends information to the primary auditory cortex in the temporal lobe. So medial equals music. Finally, the ventral anterior and ventral lateral nuclei receive input from the basal ganglia and cerebellum, and they process motor signals, which are then sent to the motor cortices in the frontal lobe. You can remember this with the phrase, Venus astronauts vow to love moving. These connections help integrate sensory and motor pathways for coordinated function. Let's talk about the limbic system, a powerful collection of neural structures that's deeply involved in emotion, long-term memory, olfaction, behavior modulation, and autonomic nervous system function. It consists of the hippocampus, the amygdalae, the mammillary bodies, the anterior thalamic nuclei, the cingulate gyrus, and the entorhinal cortex. Altogether, this system plays a key role in the classic 5 Fs, feeding, fleeing, fighting, feeling, and sex. Shifting to the dopaminergic pathways, which are commonly altered by medications, especially antipsychotics, and by movement disorders like Parkinson's disease, and let's not forget the mesocortical and mesolimbic pathways are involved in addiction behaviors. These pathways include the mesocortical, mesolimbic, nigrostriatal, and tuberoinfundibular systems. The first pathway, the mesocortical pathway, projects from the ventral tegmental area to the prefrontal cortex and is responsible for motivation and reward. When activity in this pathway is reduced, negative symptoms such as flat affect and social withdrawal may appear. However, antipsychotics tend to have limited effects on this particular pathway. The mesolimbic pathway, which travels from the ventral tegmental area to the nucleus accumbens. This pathway is associated with increased activity and is linked to positive symptoms like hallucinations and delusions. It is the primary therapeutic target of antipsychotics. Now let's talk about the nigrostriatal pathway, which runs from the substantia nigra to the dorsal striatum and plays a critical role in motor control. When activity in this pathway is reduced, extrapyramidal symptoms can emerge, which include rigidity, bradykinesia, and tremors. This pathway is significantly affected by antipsychotic drugs and is heavily impacted in Parkinson's disease. Moving to the tuberoinfundibular pathway, which extends from the hypothalamus to the pituitary gland and regulates prolactin secretion. When its activity is suppressed, prolactin levels increase. This pathway is another that's notably affected by antipsychotics. Now let's talk about the cerebellum. This beautiful structure modulates movement and plays a key role in coordination and balance, acting as a fine-tuning system for motor activity. It receives unconscious proprioceptive information from the spinal cord through the inferior cerebellar peduncle, and its output is channeled through deep nuclei, arranged from lateral to medial as dentate, emboliform, globose, and fastigial. A helpful way to remember this sequence is with the phrase, "Don't eat greasy foods." These nuclei process the signals and send them onward for motor refinement. The medial part of the cerebellum, like the vermis, is responsible for controlling axial and proximal limb musculature, and it does so bilaterally. In contrast, the lateral cerebellum, which includes the hemispheres, controls distal limb musculature on the same side, or ipsilaterally. Testing cerebellar function involves observing rapid alternating movements, like pronation and supination of the hands, as well as the finger-to-nose and heel-to-shin tests. Watching a patient's gait and checking for intention tremor are also key components. Let's now talk about how the cerebellum communicates. Inputs come through three peduncles: inferior, middle, and superior. The inferior cerebellar peduncle carries proprioceptive information from the spinal cord, while the middle peduncle brings input from the contralateral cortex. The cerebellar cortex processes this information and then sends outputs through the superior cerebellar peduncle, which connects back to the contralateral cortex. Additionally, the inner ear sends signals through the vestibular nuclei to the flocculonodular lobe, helping to regulate balance. This entire circuit ensures your movements are smooth, coordinated, and precisely timed. Now let's dive into the basal ganglia, a crucial system involved in voluntary movements and adjusting posture, marked here in the illustration. It receives cortical input and provides negative feedback to the cortex to help modulate movement precisely. The striatum consists of the putamen, which handles motor functions, and the caudate nucleus, which deals with cognitive processes. Together, the lentiform nucleus is formed by the putamen and globus pallidus. Now listen carefully as we explain the pathways involved. The direct pathway is excitatory and is sometimes called the D1 receptor pathway, or D1-rect. In this pathway, cortical input via glutamate stimulates GABA release from the striatum, which then inhibits GABA release from the internal segment of the globus pallidus, GPI. This disinhibition activates the thalamus, leading to increased motion. On the other hand, the indirect pathway, mediated by D2 receptors, is inhibitory. Here, cortical glutamate stimulates GABA release from the striatum, which inhibits GABA release from the external globus pallidus, GPE, disinhibiting the subthalamic nucleus, STN. The STN then stimulates GABA release from the GPI, inhibiting the thalamus, which reduces motion. Are you following me? Because dopamine, coming from the substantia nigra pars compacta, SNC, through the nigrostriatal pathway, plays a dual role. It stimulates the direct pathway by binding to D1 receptors and inhibits the indirect pathway by binding to D2 receptors, both actions ultimately increasing movement. Now let's put it all together visually. The substantia nigra sends inputs to the striatum, influencing both pathways. The direct pathway facilitates movement, while the indirect pathway inhibits movement, balancing each other perfectly to control motor activity. Talking about cerebral perfusion, which relies on tight autoregulation. It is primarily driven by PCO2, while PA2 also modulates perfusion during severe hypoxia, like in mountain sickness. In such cases, hypoxia increases cerebral vasodilation, which then raises cerebral blood flow and leads to cerebral edema. But that's not the whole story. Cerebral perfusion also depends on a pressure gradient between mean arterial pressure, or MAP, and intracranial pressure, or ICP. So, if blood pressure drops or if ICP rises, cerebral perfusion pressure, or CPP, will fall. The Cushing reflex is key here. It presents as a triad of hypertension, bradycardia, and respiratory depression, all in response to increased ICP. To treat elevated ICP, one approach is therapeutic hyperventilation. This reduces PCO2, which causes vasoconstriction, then lowers cerebral blood flow, and ultimately decreases ICP. This method is often used in cases of acute cerebral edema, such as secondary to stroke, especially when other treatments fail. CPP is defined by the equation CPP equals MAP minus ICP. If CPP reaches zero, then cerebral perfusion stops completely, leading to brain death, marked by coma, absent brainstem reflexes, and apnea. You should remember this. Hypoxemia will only increase CPP if the PA2 level drops below 50 mm of mercury, and CPP remains directly proportional to PCO2, at least until PCO2 exceeds 90 mm of mercury. Let's talk about the homunculus, a topographic map representing motor and sensory areas in the cerebral cortex. Its distorted appearance is due to certain body regions having richer innervation and thus greater cortical representation. The motor and sensory homunculi both span across specific cerebral arteries. The anterior cerebral artery supplies the anteromedial surface, the middle cerebral artery covers the lateral surface, and the posterior cerebral artery provides blood to the posterior and inferior surfaces of the brain. Now listen carefully as we describe the homunculus layout. The motor homunculus starts from the inner medial cerebral surface for toes and moves upward through the ankle, knee, hip, and trunk, then neck, shoulder, arm, elbow, forearm, wrist, and fingers, from the little finger to the thumb, before continuing to the brow, eye, nose, face, lips, tongue, jaw, and swallowing functions. The sensory homunculus follows a similar arrangement, covering the same regions with some overlaps, including intra-abdominal organs, the pharynx, and genitals. This layout explains why damage to specific arteries results in distinct sensory or motor deficits. Talking about watershed zones, which are critical cortical areas located between cerebral artery territories. Cortical border zones occur between the anterior and middle cerebral arteries, and between the middle and posterior cerebral arteries. Internal border zones lie between the superficial and deep territories of the middle cerebral artery. These regions are common sites for brain metastases, and infarcts in these areas often follow severe hypoperfusion. Now listen carefully. An infarct in the ACMCA watershed zone causes proximal upper extremity weakness while sparing the lower limbs, a condition often referred to as man-in-a-barrel syndrome. Meanwhile, a PCMCA watershed infarct leads to higher-order visual dysfunction. Now let's talk about the circle of Willis, which is a network of anastomoses that connects the anterior and posterior circulations. This structure plays a crucial role in maintaining cerebral perfusion during occlusion or stenosis of any major cranial artery. It includes the anterior cerebral artery, or ACA, the middle cerebral artery, or MCA, the posterior cerebral artery, or PCA, and the posterior communicating artery, or PCOM. Also involved are the anterior communicating artery, or ACOM, and the internal carotid artery, or ICA. Now listen carefully, because you should know these other arteries as well. The basilar artery, or BA, and the vertebral arteries, or VA, contribute to the posterior circulation. The anterior spinal artery, or ASA, the superior cerebellar artery, or SCA, the anterior inferior cerebellar artery, or AICA, and the posterior inferior cerebellar artery, or PICA, are also part of this complex arterial supply. This entire circle allows blood to reroute if one part is blocked, and that helps prevent ischemia in the brain. Are you following me? In the oblique lateral view, you can identify A1 and A2 segments of the ACA, P1 and P2 segments of the PCA, M1 segment of the MCA, and of course the optic chiasm. You'll also notice structures like the lenticulostriate arteries, pontine branches, and the anterior choroidal artery, which are important for deep brain perfusion. From this angle, you can also trace the aorta, the brachiocephalic trunk, the left subclavian artery, and the common carotid artery, or CCA, which branches into the external and internal carotid arteries. Now listen carefully, because we're shifting gears to the dural venous sinuses. These are large venous channels that run between the periosteal and meningeal layers of the dura mater. They drain blood from the cerebral veins, and they also receive cerebrospinal fluid from arachnoid granulations. Ultimately, all this drains into the internal jugular vein, completing the venous return from the brain. Are you following me? The superior sagittal sinus is the main location where CSF returns via the arachnoid granulations. Other key sinuses include the inferior sagittal sinus, the straight sinus, and the great cerebral vein of Galen. These structures converge at the confluence of the sinuses, and from there, blood flows through the sigmoid sinus into the internal jugular vein. Disruption of this drainage system can have serious consequences. Now let's talk about venous sinus thrombosis, which presents with signs and symptoms of increased intracranial pressure, like headache, seizures, papilledema, and focal neurologic deficits. This condition can lead to venous hemorrhage, and it is associated with hypercoagulable states, including pregnancy, oral contraceptive use, and genetic conditions such as factor V Leiden. You should remember this, it's a dangerous but treatable cause of brain dysfunction. Let's talk about the ventricular system, a crucial pathway through which cerebrospinal fluid, or CSF, circulates. It begins in the lateral ventricles, which include anterior, posterior, and inferior horns. From the lateral ventricles, CSF flows to the third ventricle through the right and left interventricular foramina of Monro. From there, it moves through the cerebral aqueduct of Sylvius to reach the fourth ventricle, and finally, it enters the subarachnoid space through the foramina of Luschka laterally and the foramen of Magendie medially. This unidirectional flow ensures proper circulation of CSF around the brain and spinal cord. The CSF is produced by the choroid plexuses, which are found in the lateral, third, and fourth ventricles. After being secreted, CSF travels to the subarachnoid space through those same foramina of Luschka and Magendie. Once it reaches the subarachnoid space, it is reabsorbed by the arachnoid granulations, which then drain it into the dural venous sinuses. This entire process keeps the intracranial environment stable, nourished, and protected. Now let's switch to the ventral view of the brainstem, starting from the top with the olfactory bulb and olfactory tract, associated with cranial nerve 1. Just below that is the optic chiasm, linked to cranial nerve 2. You'll also see the infundibulum, the mammillary body, and the pons. Extending from the pons are the middle cerebellar peduncles, while the medulla features the pyramids and the pyramidal decussation. At the base, near the spinal cord, we see C1, the first cervical spinal nerve. Now listen carefully as we go over the cranial nerves from this ventral perspective. Cranial nerve 3 and cranial nerve 4 exit the midbrain. Cranial nerve 4 is unique, it arises dorsally and immediately decussates. Cranial nerves 5 through 8 exit at the level of the pons. Cranial nerves 9 through 12 exit in the medulla. To help remember this, think of it in sets, 4 cranial nerves above the pons, 4 at the pons, and 4 in the medulla. Let's talk about their nuclei. Cranial nerves 3, 4, 6, and 12 have medial nuclei. That's easy to remember if you think in factors of 12, except for cranial nerves 1 and 2. And don't forget, those medial motor nerves follow a neat pattern that makes them easier to localize clinically. Now listen carefully as we flip to the dorsal view of the brainstem, with the cerebellum removed. You'll find the pineal gland here, which is responsible for melatonin secretion and circadian rhythm regulation. Just below that is the thalamus, and beneath the thalamus are the superior and inferior colliculi. These structures are key. Superior colliculi handle visual stimuli and guide eye and head movements toward what you see. Inferior colliculi process auditory input and help direct your gaze toward sounds. You should remember this simple rule: eyes are above ears, just as the superior colliculus for vision is above the inferior colliculus for hearing. Continuing down, we also see the superior, middle, and inferior cerebellar peduncles, which anchor the cerebellum to the brainstem. Finally, on the anterior wall of the fourth ventricle, you'll find structures connected to both motor and sensory pathways. The cranial nerve nuclei are located in a specific part of the brainstem known as the tegmentum, which lies between the dorsal and ventral regions. In the midbrain, you will find the nuclei of cranial nerves 3 and 4. Moving down to the pons, you'll find the nuclei for cranial nerves 5, 6, 7, and 8. In the medulla, the nuclei for cranial nerves 9, 10, and 12 are located. Lastly, in the spinal cord, you will find the nucleus for cranial nerve 11. This organized distribution helps localize lesions within the brainstem more precisely. Talking about the lateral and medial arrangement. The lateral nuclei are sensory in function, derived from the alar plate, while the medial nuclei are motor, derived from the basal plate. Between them lies a crucial anatomical divider called the sulcus limitans. This medial-lateral separation is consistent throughout the brainstem, helping us understand the structural logic behind cranial nerve distribution. Are you following me? Let's now discuss the vagal nuclei and their individual roles. The nucleus tractus solitarius carries visceral sensory information, including taste, signals from baroreceptors, and gut distension. It may also play a role in triggering vomiting. This nucleus receives input from cranial nerves 7, 9, and 10. Next, the nucleus ambiguus provides motor innervation to the pharynx, larynx, and upper esophagus. It's essential for swallowing and elevating the palate, and it functions through cranial nerves 9 and 10. Let's not forget the dorsal motor nucleus, which sends autonomic, parasympathetic fibers to the heart, the lungs, and the upper gastrointestinal tract. This nucleus operates exclusively through cranial nerve 10, contributing to vital parasympathetic regulation in the thoracic and abdominal organs. Now let's switch gears and look at brainstem cross-sections, starting with the midbrain. In this section, you'll find the medial lemniscus running centrally, carrying ascending sensory information. Just nearby lies the red nucleus, which plays a role in motor coordination. Then we have the substantia nigra, deeply involved in dopamine production and motor control. The cerebral peduncles flank the front of the midbrain, carrying descending motor tracts to the body. Above these, the superior colliculus processes visual input, and running through the midbrain, the cerebral aqueduct allows cerebrospinal fluid to pass from the third to the fourth ventricle. And finally, don't forget, this level of the midbrain is where cranial nerve 3 emerges, linking this whole system to oculomotor function. Now listen carefully. The cranial nerves and their associated vessel pathways travel through specific openings in the cranial fossae. Starting anteriorly, in the anterior cranial fossa, which passes through the ethmoid bone, we have the cribriform plate, which transmits cranial nerve 1. As we move into the middle cranial fossa, which courses through the sphenoid bone, you'll find the optic canal carrying cranial nerve 2 and the ophthalmic artery. Nearby lies the superior orbital fissure, which allows passage for cranial nerves 3, 4, 6, and the first division of cranial nerve 5. Now let's continue. The foramen rotundum transmits cranial nerve 5, specifically its second division, while the foramen ovale carries the third division of cranial nerve 5. Just posterior to that, the foramen spinosum is the entry point for the middle meningeal artery. Still within the middle fossa, we also find the internal auditory meatus, which transmits cranial nerves 7 and 8. These openings are critical for the proper routing of both sensory and motor information. Are you following me? Now let's shift our focus to the posterior cranial fossa, which passes through either the temporal or occipital bones. The jugular foramen transmits cranial nerves 9, 10, and 11, as well as the jugular vein. The foramen magnum is home to the vertebral arteries, the spinal root of cranial nerve 11, and the brainstem and spinal cord themselves. Lastly, the hypoglossal canal carries cranial nerve 12. Now let's talk about the cranial nerves in relation to arteries. At the level of the midbrain, cranial nerve 3 lies near the posterior communicating artery and the posterior cerebral artery. Moving into the pons, cranial nerves 5 through 8 are found near arteries like the superior cerebellar, anterior inferior cerebellar, and labyrinthine. The basilar artery lies along the ventral pons, supplying much of the brainstem. And remember, at the level of the medulla, cranial nerves 9, 10, 11, and 12 are closely associated with the vertebral arteries, the posterior inferior cerebellar artery, and the anterior spinal artery. Now listen closely, the internal carotid artery gives rise to the anterior cerebral artery, which is linked to its contralateral counterpart via the anterior communicating artery. Also branching from the internal carotid is the middle cerebral artery and the ophthalmic artery, and don't forget the anterior choroidal artery, which courses near cranial nerve 3. Now let's talk about the cranial nerves, beginning with the first, the olfactory nerve, or cranial nerve 1, which is responsible for smell, and it's the only cranial nerve without a thalamic relay to the cortex, and it's purely sensory. Then we move to cranial nerve 2, the optic nerve, responsible for sight, and it is also sensory. Next, cranial nerve 3, the oculomotor nerve, controls eye movement through the superior rectus, inferior rectus, medial rectus, and inferior oblique muscles, and it also manages pupillary constriction via the sphincter pupillae, accommodation through the ciliary muscle, and eyelid opening using the levator palpebrae. This nerve is motor. Cranial nerve 4, the trochlear nerve, is also motor, and it controls eye movement through the superior oblique muscle, crosses the midline, and is the only cranial nerve with contralateral function. Then comes the trigeminal nerve, cranial nerve 5, which is both motor and sensory, handling mastication and facial sensation through its 3 divisions, ophthalmic, maxillary, and mandibular, and it also senses from the anterior 2/3 of the tongue, while dampening loud noises using the tensor tympani muscle. Now listen carefully as we reach cranial nerve 6, the abducens, which is motor and controls the lateral rectus for eye movement. Next, cranial nerve 7, the facial nerve, is both sensory and motor, handling facial movement, eye closing through the orbicularis oculi, auditory volume modulation via the stapedius, and taste from the anterior 2/3 of the tongue through the chorda tympani, and it also contributes to lacrimation and salivation, especially in the submandibular and sublingual glands. Cranial nerve 8, the vestibulocochlear, is sensory and deals with hearing and balance. Then comes the glossopharyngeal nerve, cranial nerve 9, which is both, and it senses taste and touch from the posterior third of the tongue, controls swallowing, manages parotid salivation, and monitors the carotid body and sinus for chemo and baroreception, while also helping elevate the pharynx and larynx via the stylopharyngeus muscle. Moving on to cranial nerve 10, the vagus nerve, which is both motor and sensory, and it controls taste from the supraglottic region, swallowing, soft palate elevation, midline uvula control, speech, the cough reflex, and parasympathetic output to thoraco-abdominal viscera, while also monitoring aortic arch chemo and baroreceptors. Are you ready for cranial nerve 11, the accessory nerve? It is motor and helps with head turning and shoulder shrugging by innervating the sternocleidomastoid and trapezius muscles. Finally, cranial nerve 12, the hypoglossal nerve, is motor and moves the tongue. To help remember the function types, we use the mnemonic, some say merry money, but my brother says big brains matter most, where sensory, motor, or both align with cranial nerves 1 through 12. Let's transition to the cranial nerve reflexes. The afferent limb of the accommodation reflex is cranial nerve 2, while the efferent limb is cranial nerve 3. For the corneal reflex, afferent input comes from V1, the ophthalmic branch, specifically the nasociliary branch, and efferent output is bilateral from cranial nerve 7, using the temporal and zygomatic branches of the facial nerve, activating the orbicularis oculi. You should remember this. The cough reflex involves both afferent and efferent input from cranial nerve 10, with support from the phrenic and spinal nerves. The gag reflex uses cranial nerve 9 for afferent sensing, and cranial nerve 10 for efferent response. For the jaw jerk reflex, the afferent signal comes from V3, through muscle spindle fibers of the masseter, and the efferent signal is also via V3, causing the masseter to contract. Lastly, for the lacrimation reflex, V1 is the afferent limb, and loss of this reflex does not eliminate emotional tears, while cranial nerve 7 provides the efferent pathway. As for the pupillary reflex, it involves cranial nerve 2 as afferent, and cranial nerve 3 as efferent. Begin with the muscles of mastication. There are three main muscles that close the jaw: masseter, temporalis, and medial pterygoid, and you can remember them with the phrase, "my teeth munch." But when it comes to opening the jaw, that's the job of the lateral pterygoid, which not only lowers the jaw but also protrudes it. All of these muscles, both the closers and the opener, are innervated by the mandibular branch of the trigeminal nerve, that is, cranial nerve V3. Moving on to spinal nerves. There are 31 pairs in total, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. Cervical nerves C1 through C7 exit above their corresponding vertebrae, for example, C3 exits above the third cervical vertebra. But the C8 spinal nerve is unique, it exits below C7 and above T1. From that point on, all other spinal nerves exit below their corresponding vertebrae, so L2 exits just below the second lumbar vertebra. We're going deeper into the spinal cord's anatomy. In adults, the spinal cord ends at the lower border of the L1 to L2 vertebrae. However, the subarachnoid space, which holds cerebrospinal fluid or CSF, extends further down to the lower border of the S2 vertebra. This is important, because lumbar puncture is usually done between L3 and L4 or between L4 and L5. That's the level of the cauda equina, and it's the safest place to sample CSF while avoiding injury to the spinal cord. You can remember it this way: to keep the cord alive, keep the spinal needle between L3 and L5. Now let's walk through the layers the needle passes through during a lumbar puncture. First, it goes through the skin, then fascia and fat, followed by the supraspinous ligament, and then the interspinous ligament. After that, it reaches the ligamentum flavum, and enters the epidural space. This is where an epidural anesthesia needle would stop. But for a lumbar puncture, the needle continues, passing through the dura mater, then the arachnoid mater, and finally enters the subarachnoid space, where the CSF is collected. Now listen carefully as we talk about the conus medullaris and cauda equina syndrome. These are rare neurosurgical emergencies caused by compression of the terminal end of the spinal cord, the conus medullaris, or of the lumbosacral spinal nerve roots, known as the cauda equina. This compression may be due to disc herniation, tumors, or trauma, and the presentation includes radicular low back pain, saddle or perianal anesthesia, bladder and bowel dysfunction, and lower limb weakness. In conus medullaris syndrome, symptoms are symmetric, with upper motor neuron signs like spasticity. In cauda equina syndrome, symptoms are asymmetric and show lower motor neuron signs, such as flexidity. Are you ready to continue? Now let's talk about spinal cord levels and associated tracts. In the lateral corticospinal and spinothalamic tracts, the legs, meaning the lumbosacral fibers, are positioned laterally. Meanwhile, the dorsal columns are arranged just like your body, with your hands at your sides. This gives us the phrase, arms outside, legs inside, as a way to remember their organization. The cervical spinal cord has 2 dorsal columns and a prominent lateral horn. The thoracic level features 1 dorsal column, while the ventral horn becomes more visible in the lumbosacral level. Talking about spinal tract anatomy and their functions. Remember, the spinothalamic tract and the dorsal column are ascending tracts, and both synapse first and then cross over. In contrast, the corticospinal tract is a descending tract, it crosses first and then synapses. The spinothalamic tract carries pain and temperature, while the dorsal column handles pressure, vibration, fine touch, and conscious proprioception. The corticospinal tract is responsible for voluntary movement. You know how these tracts work. The first-order neuron in the spinothalamic tract starts from a sensory nerve ending, A delta and C fibers, part of a pseudounipolar neuron in the dorsal root ganglion. It enters the spinal cord. In the dorsal column, the first-order neuron is also from a sensory nerve ending of a pseudounipolar neuron, entering the spinal cord and ascending ipsilaterally in the dorsal columns. Meanwhile, for the corticospinal tract, the upper motor neuron begins in the primary motor cortex, descends ipsilaterally through the posterior limb of the internal capsule and cerebral peduncle, then decussates at the caudal medulla in the pyramidal decussation, and finally descends contralaterally, diving into the synapse points. In the spinothalamic tract, the first synapse is in the posterior horn of the spinal cord. In the dorsal column, it's in the nucleus gracilis, medial for lower limbs below T6, and the nucleus cuneatus, lateral for upper limbs above T6, in the ipsilateral medulla. Remember the mnemonic, grass on the ground, clouds in the sky. For the corticospinal tract, the first synapse happens in the anterior horn of the spinal cord. Now let's focus on the second-order neurons. In the spinothalamic tract, the second-order neuron decussates in the spinal cord through the anterior white commissure and then ascends contralaterally. In the dorsal column, it decussates in the medulla and then ascends contralaterally as the medial lemniscus. In the corticospinal tract, the lower motor neuron leaves the spinal cord after synapsing. The second synapse for the sensory tracts happens in the VPL of the thalamus, while for the motor tract, it occurs at the neuromuscular junction of the skeletal muscle. Finally, the third-order neurons of the sensory tracts project to the primary somatosensory cortex. Now listen carefully as we go through clinical reflexes. These reflexes count up in order, and the main nerve roots are important to remember. The Achilles reflex involves S1 and S2, think, buckle my shoe. The patellar reflex uses L2 to L4, think, kick the door. The biceps and brachioradialis reflexes involve C5 and C6, which you can remember as, pick up sticks. The triceps reflex covers C6, C7, and C8, so think, lay them straight. Other reflexes include the cremasteric reflex, which is L1 and L2, testicles move, and the anal wink reflex, which uses S3 and S4, or winks galore. Now let's talk reflex grading. A grade of 0 means the reflex is absent. 1+ means it's hypoactive. 2+ is normal. 3+ is hyperactive. And 4+ means clonus is present. Keep those numbers in mind when checking reflex integrity across spinal levels, like C5 and C6, L2 through L4, C6 to C8, or S1 and S2, each tells you something important about neural function. Now let's go into primitive reflexes. These are central nervous system reflexes seen in healthy infants but should disappear within the first year of life due to inhibition by the developing frontal lobe. They are normally absent in a healthy adult but may reappear in adults who suffer from frontal lobe lesions, which indicates a loss of inhibition. The Moro reflex, also known as the hang-on for life reflex, involves abducting and extending the arms when startled, followed by drawing them together. The rooting reflex is movement of the head toward one side if the cheek or mouth is stroked, signaling nipple seeking. The sucking reflex involves a sucking response when the roof of the mouth is touched. Are you still with me? Because now we're explaining more. The palmar reflex is curling of the fingers when the palm is stroked. The plantar reflex causes dorsiflexion of the large toe and fanning of the other toes when the sole is stimulated. When this appears in an adult, it's called the Babinski sign, which could mean an upper motor neuron lesion. The Gallant reflex is observed when you stroke along one side of the spine while a newborn is in ventral suspension. This causes the lower body to laterally flex toward the stimulated side. Now let's finish with landmark dermatomes and their characteristics. C2 corresponds to the posterior half of the skull. C3 gives sensation at the high turtleneck shirt level. Referred pain from the diaphragm and gallbladder goes to the right shoulder via the phrenic nerve. C3, C4, and C5 keep the diaphragm alive. C4 matches the low collar shirt area. C6 includes the thumbs, think thumbs up on your left hand, which looks like a 6. T4 is at the nipple, remember, T4 at the teat pore. T7 aligns with the xiphoid process. There are 7 letters in xiphoid. T10 is at the umbilicus or belly button and is the site of referred pain in early appendicitis. Are you ready for the lower levels? L1 is at the inguinal ligament. L4 includes the kneecaps, think of being down on all fours. Finally, S2, S3, and S4 are responsible for the sensation in penile and anal zones. That's why we say, S2, 3, for keep the penis off the floor. Now let's talk about common brain lesions, beginning with the prefrontal cortex, where damage causes frontal lobe syndrome. This includes disinhibition, hyperphagia, impulsivity, loss of empathy, impaired executive function, and sometimes akinetic mutism, all of which are seen in frontotemporal dementia. Moving on to the frontal eye fields, lesions here cause the eyes to look toward the brain lesion, which means away from the side of hemiplegia, a pattern typically observed in middle cerebral artery strokes. In contrast, damage to the paramedian pontine reticular formation causes the eyes to look away from the lesion, meaning toward the hemiplegic side, and this distinction helps localize brainstem injury during examination. Let's explore the parietal cortex, where lesions in the dominant side result in Gerstmann syndrome, which involves agraphia, acalculia, finger agnosia, and left-right disorientation. On the non-dominant parietal cortex, however, the consequence is hemispecial neglect syndrome, where the person experiences agnosia of the contralateral side of the world. In the basal ganglia, damage leads to tremor at rest, chorea, and athetosis, as observed in both Parkinson and Huntington disease. But in the subthalamic nucleus, lesions cause contralateral hemibolismus, a violent, flinging motion of the limbs. Now listen carefully, because the mammillary bodies, when bilaterally lesioned, result in Wernicke-Korsakoff syndrome, due to thiamine deficiency. And the amygdala, when damaged on both sides, causes Kluver-Bucy syndrome, characterized by disinhibition, hyperphagia, hypersexuality, and hyperorality, commonly seen in HSV-1 encephalitis. The hippocampus, when bilaterally affected, leads to anterograde amnesia, preventing the formation of new memories, a hallmark of Alzheimer's disease. A lesion in the dorsal midbrain causes Parnot syndrome, often from pineal gland tumors, while a lesion in the reticular activating system reduces arousal and wakefulness, even resulting in coma. Are you ready for more? In the medial longitudinal fasciculus, damage leads to internuclear ophthalmoplegia, where there's impaired adduction of the ipsilateral eye and nystagmus of the contralateral eye with abduction, a condition commonly seen in multiple sclerosis. The cerebellar hemisphere, when damaged, causes intention tremor, limb ataxia, and loss of balance, producing ipsilateral deficits and causing the person to fall toward the lesion. In contrast, the cerebellar vermis, when affected, results in truncal ataxia, wide-based gait, Run-Ken-Saylor gait, nystagmus, and dysarthria, with degeneration linked to chronic alcohol use. You can remember, since the vermis located centrally, it affects the central body. Now let's talk about abnormal motor posturing. In decorticate posturing, which results from a lesion above the red nucleus, such as in the cerebral cortex, the rubrospinal and vestibulospinal tracts are overactive, leading to upper limb flexion and lower limb extension. Your hands are near the cor, meaning heart. But in decerebrate posturing, caused by a lesion between the red and vestibular nuclei, both upper and lower limbs are extended due to vestibulospinal overactivity, and this presentation carries a worse prognosis. The red nucleus, rubrospinal tract, and vestibular nucleus all contribute to these postural patterns, helping distinguish lesion locations. Now listen carefully, as we shift to ischemic brain disease and stroke. Which is irreversible neuronal injury starts after just 5 minutes of hypoxia. Most vulnerable area are the hippocampus, specifically the CA1 region, along with the neocortex, cerebellum Purkinje cells, and watershed areas, which we remember with the phrase, vulnerable hippos need pure water. When diagnosing stroke, non-contrast CT is the first step to exclude hemorrhage before giving TPA, with CT detecting ischemic changes in 6 to 24 hours, while diffusion-weighted MRI can detect them within 3 to 30 minutes, making it more sensitive early on. Are you following me? Let's now break down histologic changes after ischemia over time. At 12 to 24 hours, red neurons appear with eosinophilic cytoplasm and pycnotic nuclei. By 24 to 72 hours, you see necrosis and neutrophils. Between 3 to 5 days, macrophages and microglia appear. Then, at 1 to 2 weeks, reactive gliosis and vascular proliferation occur. And after 2 weeks, the result is a glial scar, completing the repair process. Let's read about stroke. It begins with ischemia, which leads to infarction, and ultimately results in liquefactive necrosis. There are 3 types of ischemic stroke. First, the thrombotic type is caused by a clot that forms directly at the site of infarction. This most commonly occurs in the middle cerebral artery, and it usually develops over a ruptured atherosclerotic plaque. Second, the embolic type arises from an embolus that travels from another part of the body, often affecting multiple vascular territories. Examples of this include atrial fibrillation, carotid artery stenosis, deep vein thrombosis with a patent foramen ovale, which causes paradoxical embolism, and also infective endocarditis. Are you following me? The third type is the hypoxic stroke, which is due to systemic hypoperfusion or hypoxemia. This is especially common during cardiovascular surgeries, and it tends to affect watershed areas, the regions between major cerebral arteries. Treatment begins with TPA, but only if it's given within 3 to 4.5 hours of symptom onset, and only if there's no hemorrhage or risk of hemorrhage. Alternatively, thrombectomy may be performed if there is a large artery occlusion. To reduce the risk of future stroke, use medical therapy, including aspirin or clopidogrel, along with optimal control of blood pressure, blood sugar, and blood lipids. Lifestyle changes are also critical, such as smoking cessation, and treating any conditions that increase risk, like atrial fibrillation and carotid artery stenosis. Now let's move on to transient ischemic attack, or TIA. This is a brief, reversible episode of focal neurologic dysfunction, which occurs without acute infarction, and that's confirmed by a negative MRI. The majority of TIAs resolve in less than 15 minutes, and they are caused by ischemia, often from an embolus or small vessel stenosis. A classic presentation is amaurosis fugax, which is a transient visual loss due to retinal artery emboli, and it often originates from carotid artery disease. Now listen carefully. We'll end with cerebral edema, which is fluid accumulation in the brain parenchyma, leading to increased intracranial pressure. There are 2 major types of cerebral edema. The first is cytotoxic edema, which involves intracellular fluid accumulation due to an osmotic shift. This happens when the Na/Kat phosphate pump is dysfunctional, resulting in increased intracellular sodium. Cytotoxic edema is typically caused by early ischemia, hyperammonemia, or SIADH. The second type is vasogenic edema, which is an extracellular fluid accumulation that results from disruption of the blood-brain barrier, increasing its permeability. This type is caused by late-stage ischemia, as well as trauma, hemorrhage, inflammation, or tumors, and imaging often shows surrounding vasogenic edema. Let's see about the effects of strokes, beginning with those involving the anterior circulation. First, the anterior cerebral artery supplies the motor and sensory cortices, specifically the area for the lower limb. So, when there's a lesion here, it causes contralateral paralysis and sensory loss in the lower limb, and sometimes even urinary incontinence. Moving on to the middle cerebral artery, which covers the motor and sensory cortices for the upper limb and face, as well as the temporal lobe, including the Wernicke area, and the frontal lobe, where the Broca area is located. A stroke in this artery leads to contralateral paralysis and sensory loss in the lower face and upper limb. If the lesion is in the dominant hemisphere, which is usually the left, the person may develop aphasia. But if the non-dominant hemisphere is affected, usually the right, it can lead to hemineglect. Now listen carefully. Wernicke aphasia often comes with a right superior quadrant visual field defect, and that's due to temporal lobe involvement. Next is the lenticulostriate artery, which affects the striatum and the internal capsule. A stroke here causes contralateral paralysis, but without cortical signs. That means no neglect, no aphasia, and no visual field loss. This is the classic pure motor stroke, and it's the most common type seen in lacunar infarcts, which are usually due to microatheroma and hyaline arteriosclerosis, also called lipohyalinosis, and this typically results from unmanaged hypertension. Let's turn our attention to the posterior circulation. The posterior cerebral artery supplies the occipital lobe, and lesions here result in contralateral hemianopia with macular sparing. If the lesion is in a dominant hemisphere, and extends to the splenium of the corpus callosum, it can cause alexia without agraphia. But if it's in a non-dominant hemisphere, it may lead to prosopagnosia, which is the inability to recognize familiar faces. One important syndrome to remember here is Weber syndrome, which is a midbrain stroke due to occlusion of paramedian branches of the PCA. This causes ipsilateral cranial nerve 3 palsy, and contralateral hemiplegia, due to damage to the ipsilateral cerebral peduncle. Let's go deeper. The basilar artery supplies the pons, medulla, and the lower midbrain, including the corticospinal and corticobulbar tracts, as well as the ocular cranial nerve nuclei, and the paramedian pontine reticular formation. If the reticular activating system is spared, then consciousness is preserved. But if corticospinal and corticobulbar tract involved, it results quadriplegia, and a complete loss of voluntary movement of the face, mouth, and tongue, although blinking is spared. If ocular cranial nerve nuclei involved, there's also a loss of horizontal eye movements, while vertical movement remains intact. Stroke in this area results the classic locked-in syndrome, and you should remember it as being locked in the basement. Are you ready for more? Now we move on to the anterior inferior cerebellar artery, or AICA. It affects the facial nerve nuclei, the vestibular nuclei, the spinothalamic tract, and the spinal trigeminal nucleus, along with sympathetic fibers, the middle and inferior cerebellar peduncles, and even the inner ear. A stroke in this territory, depending on area affected, causes paralysis of the face, which is a lower motor neuron lesion, unlike the upper motor neuron lesion seen in cortical strokes. There's also reduced lacrimation, reduced salivation, and reduced taste from the anterior 2/3 of the tongue. You'll also see vomiting, vertigo, and nystagmus, along with reduced pain and temperature sensation from the contralateral body and the ipsilateral face. Now listen carefully, it doesn't stop there. There's also ipsilateral Horner syndrome, ipsilateral ataxia, and dysmetria, along with ipsilateral sensorineural deafness and vertigo. This is called the lateral pontine syndrome, and the facial nerve nucleus effects are specific to AICA lesions. You should remember that the labyrinthine artery, which supplies the inner ear, is a branch of AICA, and this is why the hearing loss and vertigo are so specific in this case. Now let's continue discussing the effects of strokes, focusing on the posterior inferior cerebellar artery, or PICA. This artery supplies the nucleus ambiguus, which includes cranial nerves 9 and X, the vestibular nuclei, the lateral spinothalamic tract, the spinal trigeminal nucleus, sympathetic fibers, and the inferior cerebellar peduncle. A lesion here leads to dysphagia, hoarseness, a reduced gag reflex, and hiccups. There's also vomiting, vertigo, and nystagmus, along with reduced pain and temperature sensation from the contralateral body and the ipsilateral face. You'll also see ipsilateral Horner syndrome, ipsilateral ataxia, and dysmetria. This combination of findings is known as lateral medullary syndrome, or Wallenberg syndrome. Now listen carefully, the effects on the nucleus ambiguus are specific to PICA lesions, and there's a helpful mnemonic for you: don't pick a, PICA, lame, lateral medullary syndrome, hoarseness, that can't eat, dysphagia. Are you following me? Now we move on to the anterior spinal artery, which affects the corticospinal tract, the medial lemniscus, and the caudal medulla, especially the hypoglossal nerve. This causes contralateral paralysis of both the upper and lower limbs, and a reduction in contralateral proprioception. It also leads to ipsilateral hypoglossal dysfunction, where the tongue deviates toward the same side as the lesion. This is called the medial medullary syndrome, and it's caused by an infarct of the paramedian branches of the anterior spinal artery, and sometimes the vertebral arteries. Here's a quick way to remember it: ants love M&Ms, referring to the anterior spinal artery, the medial medulla, and the classic M&M syndrome. Now let's switch gears and talk about neonatal intraventricular hemorrhage. This is bleeding into the ventricle. The risk is much higher in premature and low birth weight infants, and it originates in the germinal matrix, which is a highly vascularized layer found within the subventricular zone. This fragile area is vulnerable due to reduced glial fiber support and impaired blood pressure regulation in preterm babies. Clinical signs may include an altered level of consciousness, a bulging fontanelle, hypotension, seizures, or even coma. Are you ready for more? Now we'll cover some extracranial injuries that can occur during birth, and these involve blood accumulation within the scalp and skull, most commonly seen with vacuum-assisted deliveries. The first condition is caput succedaneum, which is a self-limited, benign, and edematous swelling that occurs above the periosteum, and it crosses suture lines. It often results from prolonged fetal engagement in the birth canal, and it resolves on its own. Next is subgaleal hemorrhage, which is serious and life-threatening, caused by damage to the fetal emissary veins, leading to blood collecting between the periosteum and the galea aponeurosis. This presents as diffuse, fluctuant swelling of the scalp that may extend posteriorly and laterally, and it can cause anemia or hypovolemic shock. Now listen carefully, the last one is cephalohematoma, where blood collects between the skull and periosteum, and this one does not cross suture lines. It's often caused by forceps delivery, and presents as a firm, localized swelling over the parietal or occipital lobe. It may also lead to indirect hyperbilirubinemia as the blood breaks down. Now let's talk about intracranial hemorrhages, beginning with the epidural hematoma. This condition results from rupture of the middle meningeal artery, a branch of the maxillary artery, often due to a skull fracture, particularly at the pterion, which is the thinnest area of the lateral skull. Patients might initially experience a transient loss of consciousness, followed by a brief recovery phase, also called a lucid interval, but then rapidly deteriorate as the hematoma expands. You should remember this: scalp hematoma, and rapid intracranial expansion, can lead to transtentorial herniation and cranial nerve 3 palsy. On CT imaging, this appears as a biconvex, or leniform, hyperdense blood collection that does not cross suture lines. Now listen carefully, next we have the subdural hematoma, which is caused by rupture of bridging veins. This condition can present in 2 forms: acute, typically following traumatic, high-energy impact, appearing brighter or hyperdense on CT, and chronic, associated with mild trauma, cerebral atrophy, advanced age, or chronic alcohol use, and appears darker or hypodense on CT. It is also commonly seen in shaken babies. The characteristic appearance is a crescent-shaped hemorrhage, which crosses suture lines. It can cause a midline shift, and sometimes you'll find both acute hyperdense borders and chronic hypodense crescents together. Are you following me? Now let's move to the subarachnoid hemorrhage, which involves bleeding, either due to trauma or rupture of an aneurysm, such as a saccular aneurysm, or from an arteriovenous malformation. The onset is rapid, and patients often describe it as the worst headache of their life. A lumbar puncture in such cases can show bloody or yellow-tinged fluid, known as xanthochromia. There's also a risk of vasospasm, occurring due to blood breakdown or rebleeding, usually between 3 to 10 days after the initial event, leading to ischemic infarct. For prevention or reduction of vasospasm, nimodipine is used. Also, be alert for increased risk of developing both communicating and non-communicating hydrocephalus. Now let's wrap up with the intraparenchymal hemorrhage, which is most commonly caused by systemic hypertension. But it's also associated with amyloid angiopathy, which leads to recurrent lobar hemorrhagic strokes in older adults, as well as arteriovenous malformations, vasculitis, and neoplasms. It can also occur secondary to reperfusion injury following an ischemic stroke. One specific type, known as hypertensive hemorrhage, often due to Charcot-Bouchard microaneurysms, tends to occur in the putamen and globus pallidus, which are parts of the basal ganglia supplied by lenticulostriate vessels. Other common sites include the internal capsule, thalamus, pons, and cerebellum. Now let's talk about thalamic pain syndrome, a condition characterized by severe, treatment-resistant neuropathic pain that follows thalamic lesions. It is often caused by occlusion of a lenticulostriate artery. The presentation usually begins with initial paresthesias, and then, over a course of weeks to months, patients may develop allodynia, which means that ordinarily painless stimuli now cause pain, along with hyperalgesia, a heightened sensitivity to pain, and dysesthesia, or altered sensation, all occurring on the contralateral side of the lesion. Now listen carefully. Next is phantom limb pain, which involves sensations of burning, aching, or even electric shock-like pain in a limb that has been amputated and is no longer physically present. This phenomenon is common after amputation and is associated with reorganization of the primary somatosensory cortex, which means the brain continues to interpret sensory inputs as if the limb were still there, even though it has been removed. Are you following me? Now let's move to something more traumatic: diffuse axonal injury, a condition caused by traumatic shearing of white matter tracts during rapid acceleration or deceleration of the brain, such as in a motor vehicle accident. The result is often a devastating neurologic injury, which can cause coma or even lead to a persistent vegetative state. On MRI, this condition typically shows multiple punctate hemorrhages, affecting white matter tracts, and these microscopic injuries can disrupt communication between different regions of the brain. Now let's turn to the topic of aphasia, which refers to a higher-order language deficit, meaning an individual loses the ability to understand, produce, or use language appropriately. It's caused by damage to the dominant cerebral hemisphere, which is usually the left hemisphere. And don't confuse this with dysarthria, which is a motor inability to produce speech, more related to a movement deficit than to language comprehension or expression. Now listen carefully as we discuss the types of aphasia. First is Broca's aphasia, also known as expressive aphasia, which results from damage to the Broca area in the inferior frontal gyrus of the frontal lobe. Patients exhibit non-fluent speech but have intact language comprehension. They often appear frustrated because they understand what's being said but struggle to express themselves, and importantly, insight remains intact. You should remember this simple phrase: Broca is broken boca, with boca meaning mouth in Spanish. Now let's continue with Wernicke's aphasia, or receptive aphasia, caused by damage to the Wernicke area in the superior temporal gyrus of the temporal lobe. Patients speak in a fluent manner, but their language comprehension is impaired, and they often produce meaningless or jumbled sentences. This is sometimes described as a word salad. Unlike in Broca's aphasia, patients do not realize their speech doesn't make sense, and insight is absent. Are you ready for the next one? Conduction aphasia results from damage to the arcuate fasciculus, the white matter tract that connects Broca's and Wernicke's areas. In this condition, patients have impaired speech repetition, even though they may have relatively intact comprehension and fluency. Finally, we have global aphasia, which occurs when both Broca's and Wernicke's areas are affected. These patients show non-fluent speech combined with impaired language comprehension. Let's talk about aneurysms, which refer to the abnormal dilation of an artery due to weakening of the vessel wall. One important type is the saccular aneurysm, also called a Berry aneurysm, which most often occurs at bifurcations in the circle of Willis. The most common site for this aneurysm is the junction of the anterior communicating artery and the anterior cerebral artery. It's associated with conditions like autosomal dominant polycystic kidney disease, and Ehlers-Danlos syndrome, while other risk factors include advanced age, hypertension, and tobacco smoking. These aneurysms are usually clinically silent until they rupture, and when they do, the most common complication is a subarachnoid hemorrhage, described by patients as the worst headache of my life, or a thunderclap headache, followed by focal neurologic deficits. But even before rupture, the growing aneurysm can cause symptoms through direct compression of surrounding structures, which depends on its specific location in the brain's vascular system. Let's break it down by site. If the aneurysm is near the anterior communicating artery, it can compress the optic chiasm, leading to bitemporal hemianopia and visual acuity deficits, and if it ruptures, it may cause ischemia in the anterior cerebral artery distribution, resulting in contralateral lower extremity hemiparesis and sensory deficits. If it's in the middle cerebral artery, rupture can lead to ischemia in the MCA distribution, resulting in contralateral upper extremity and lower facial hemiparesis, along with sensory deficits. And if the aneurysm affects the posterior communicating artery, compression may cause an ipsilateral third cranial nerve palsy, presenting with mydriasis, also called a blown pupil, and possibly ptosis with a down and out eye. Let's talk briefly about Charcot-Bouchard microaneurysms, which are common and associated with chronic hypertension. These aneurysms affect small vessels, such as the lenticulostriate arteries in areas like the basal ganglia and thalamus, and can lead to hemorrhagic intraparenchymal strokes. It's important to know that these microaneurysms are not visible on angiography, making them a more hidden but serious pathology. Now shifting gears, let's compare fever and heat stroke, two conditions with very different pathophysiology. Fever is caused by cytokine activation during inflammation, often due to infection, whereas heat stroke results from the body's inability to dissipate heat, for example during exertion. With fever, the temperature is usually less than 40 degrees Celsius, or 104 degrees Fahrenheit, while in heat stroke, the temperature is usually greater than 40 degrees Celsius, meaning it rises dangerously high. Now listen carefully. Complications of fever may include febrile seizures, which are generally benign and self-limiting, whereas heat stroke can cause central nervous system dysfunction, including confusion, and may also lead to rhabdomyolysis, acute kidney injury, acute respiratory distress syndrome, and disseminated intravascular coagulation. When it comes to treatment, fever is managed with acetaminophen or ibuprofen for comfort, and antibiotics if indicated, but for heat stroke, you need rapid external cooling, along with rehydration and correction of electrolytes. Seizures are characterized by synchronized, high-frequency neuronal firing, and they consist of three important phases. First comes the aura, which is the early part of a seizure and may include odd smells or tastes. Then we move into the ictal phase, which is the time from the first symptom to the end of seizure activity. Finally, there is the postictal phase, which is the period of gradual recovery, back to the pre-seizure baseline level of function and awareness. Now let's talk about focal seizures, which originate in a single area of the brain, most commonly in the medial temporal lobe, and these can be divided into different types. The first type is focal aware seizures, formerly called simple partial seizures, and in this type, consciousness remains intact. Symptoms may include motor signs, sensory changes, autonomic alterations, or even psychic manifestations. The second type is focal impaired awareness seizures, previously known as complex partial seizures, where there is impaired consciousness, often accompanied by automatisms, which are involuntary movements or behaviors. Are you following me? Epilepsy is defined as a disorder of recurrent, unprovoked seizures, and it's important to remember that febrile seizures are not considered epilepsy. Now let's continue with a serious emergency. Convulsive status epilepticus refers to continuous seizure activity lasting 5 minutes or more, or recurring seizures without any return to baseline consciousness in between. This condition can result in brain injury, so it's a critical scenario. Now listen carefully, the causes of seizures vary by age group. In children younger than 18 years, the causes are often genetic, infectious, such as febrile seizures, traumatic, congenital, or metabolic in origin. For adults aged 18 to 65, causes include tumors, trauma, strokes, and infections, while in adults older than 65, the most common causes are stroke, tumor, trauma, metabolic disturbances, and infections. Next, let's talk about psychogenic non-epileptic events, which can resemble prolonged episodes, often lasting more than 1 minute, and they may look like syncopal or tonic-clonic episodes. However, these lack a postictal phase, and they also do not include features like autonomic disturbances or tongue biting. They are often accompanied by vocalizations and a preceding aura, and they tend to occur more frequently in females. You should remember this. Risk factors include a history of psychiatric disorders and substance use, and EEG findings during these episodes are typically normal when recorded on video EEG. Now let's talk about generalized seizures, which are diffuse, and come in several types. Absence seizures, also called petit mal, show 3 Hz spike N-wave discharges on EEG. These are short, usually lasting about 10 seconds, and they occur frequently. The person may appear to stare blankly, and may exhibit automatisms, but there is no postictal confusion, and episodes can be triggered by hyperventilation. Then we have myoclonic seizures, which involve quick and repetitive jerks, but without any loss of consciousness or postictal confusion. Are you ready to keep going? The tonic-clonic seizure, also called grand mal, is characterized by alternating phases of stiffening and movement. These seizures do include postictal confusion, and may involve urinary incontinence and tongue biting. Tonic seizures involve only the stiffening phase, while atonic seizures, often called drop seizures, result in a sudden loss of muscle tone, causing the person to fall to the floor, and they are commonly mistaken for fainting. You should remember that seizures can evolve from focal to generalized forms, and different clinical signs may help distinguish them. Now listen carefully. Some helpful features include whether consciousness is impaired or not. Focal seizures may be either focal aware, where consciousness is preserved, or focal impaired awareness, where there is a disruption in consciousness. In generalized seizures, types include tonic-clonic, which involves stiffening followed by rhythmic jerking, tonic, which is just the stiffening, myoclonic, with quick, repetitive jerks, atonic, which leads to sudden falls, and absence seizures, which are characterized by a blank stare and no postictal confusion. Headaches are defined as pain caused by irritation of either intra- or extracranial structures, such as the meninges and blood vessels, and they are broadly classified into primary and secondary types. Now let's talk about primary headaches, which include tension-type, migraine, and cluster headaches, while secondary headaches are caused by underlying issues like medication overuse, meningitis, subarachnoid hemorrhage, hydrocephalus, neoplasia, and giant cell arteritis. You should remember this: tension-type headaches are bilateral, usually lasting more than 30 minutes and often around 4 to 6 hours, presenting with steady, band-like pain, and notably, there is no nausea or vomiting. Also, only one of either photophobia or phonophobia may be present, and there's no aura. It is the most common primary headache and occurs more often in females, and when it comes to treatment, acute episodes are managed with analgesics, NSAIDs, or acetaminophen, while for prevention, TCAs like amitriptyline and behavioral therapy are helpful. Now listen carefully. Migraines are unilateral and last from 4 to 72 hours, they bring pulsating pain that comes with nausea, photophobia, and phonophobia, and sometimes may be preceded by an aura. This pain is believed to be due to irritation of cranial nerve 5, the meninges, or blood vessels, and involves the release of vasoactive neuropeptides, including substance P and calcitonin gene-related peptide. Migraines occur more commonly in females, and the pound mnemonic can help you recall the features: pulsatile quality, 1-day duration, unilateral location, nausea, and a disabling intensity. For acute attacks, treatment includes NSAIDs, triptans, dihydroergotamine, and antiemetics like prochlorperazine and metoclopramide. For prevention, lifestyle changes such as regulating sleep, exercise, and diet are important, along with medications like beta blockers, amitriptyline, topiramate, valproate, botulinum toxin, and anti-CGRP monoclonal antibodies. Are you following me? Cluster headaches, on the other hand, are also unilateral but are brief and occur repetitively, usually lasting between 15 minutes and 3 hours, and they are described as excruciating periorbital pain that comes with autonomic symptoms like lacrimation, rhinorrhea, and conjunctival injection. They may also present with Horner syndrome, and they are more common in males. For acute treatment, sumatriptan and 100% oxygen are the most effective options, while verapamil is used for prophylaxis. Now let's talk about trigeminal neuralgia, which affects branches V1, V2, and V3 of the trigeminal nerve and is characterized by recurrent, brief episodes of intense unilateral pain in this distribution, usually involving the second and third branches. Most cases are due to compression of the trigeminal nerve root by an aberrant vascular loop, and the pain is typically described as electric shock, like or stabbing, with each episode lasting only seconds. The attacks are usually triggered by light facial touch or by facial movements such as chewing or talking. Treatment of choice includes carbamazepine and oxcarbazepine. Talking about dyskinesias, which are disorders of movement that result from abnormal activity in motor pathways, often involving the basal ganglia, cerebellum, or associated neural circuits. Akathisia is one of these. and it presents as restlessness and an intense urge to move, and it can be seen with neuroleptic use or as an adverse effect of Parkinson's disease treatment. Moving on, asterixis is described as a flapping motion that appears when the wrists are extended, and this sign is commonly associated with hepatic encephalopathy, Wilson disease, and various other metabolic derangements that affect neurological function. Athetosis is another form of dyskinesia and is characterized by slow, snake-like, writhing movements that are especially seen in the fingers, and this condition is caused by a lesion to the basal ganglia. It is also a feature commonly seen in Huntington's disease, further highlighting its basal ganglia origin. Now listen carefully. Chorea is a movement disorder defined by sudden, jerky, and purposeless movements, and its name originates from the Greek word for dancing. Like athetosis, chorea is also caused by lesions to the basal ganglia, and it is a hallmark feature of Huntington's disease, but it can also be seen in acute rheumatic fever, where it is referred to as sydenham chorea. Moving on to dystonia, which involves sustained, involuntary muscle contractions, and it can lead to specific conditions such as writer's cramp, blepharospasm, and torticollis. For treatment, botulinum toxin injections are commonly used to relieve the muscle overactivity. Next up is essential tremor, a high-frequency tremor that occurs with sustained posture, such as holding outstretched arms, and it tends to worsen with movement or anxiety. It is often familial in nature, and many patients self-medicate with alcohol, which reduces the tremor amplitude. Treatment includes non-selective beta blockers like propranolol and barbiturates such as primidone. Are you ready for more? Intention tremor refers to a slow, zigzag motion that appears when the person is pointing or extending toward a target, and this kind of tremor is caused by cerebellar dysfunction. In contrast, resting tremor is characterized by uncontrolled movement of distal appendages, especially the hands, and the tremor improves with intentional movement. It is caused by a lesion to the substantia nigra and is often seen in Parkinson's disease, where it is classically described as a pill-rolling tremor. The mnemonic here is helpful. When you park your car, it is at rest, just like resting tremor occurs when the body is at rest. Now listen carefully. Hemibolismus is a dramatic movement disorder involving sudden, wild flailing of one side of the body, and it is caused by a lesion to the contralateral subthalamic nucleus, often due to a lacunar stroke. The name hemibolismus reflects the nature of the condition. Half of the body is going ballistic. Moving on to myoclonus, it involves sudden, brief, and uncontrolled muscle contractions, and it presents as jerks or hiccups. Myoclonus is common in metabolic abnormalities such as renal and liver failure and is also seen in Creutzfeldt-Jakob disease. Restless leg syndrome presents with uncomfortable sensations in the legs, creating an irresistible urge to move them, especially during periods of inactivity, with symptoms becoming most prominent in the evening or at night. The discomfort is transiently relieved by movement, such as walking. This condition is usually idiopathic and often has a genetic predisposition, but it may also be associated with iron deficiency, chronic kidney disease, or diabetes mellitus, particularly when neuropathy is present. Treatment options include gabapentinoids and dopamine agonists. Now let's talk about neurodegenerative movement disorders, beginning with Parkinson's disease, which is caused by the loss of dopaminergic neurons in the substantia nigra pars compacta, and this leads to depigmentation, as seen in imaging. Symptoms usually appear after the age of 60 and can be remembered with the mnemonic, body trap. This includes tremor, specifically a pill-rolling tremor at rest, rigidity, either cogwheel or lead pipe in nature, akinesia or bradykinesia which presents as a shuffling gait or small handwriting called micrographia, and finally, postural instability, which reflects a tendency to fall. Dementia tends to occur later in the course of the disease. Affected neurons also contain Lewy bodies, which are intracellular eosinophilic inclusions composed of alpha-synuclein. This is why we say, Parkinsonuclein. Now listen carefully. Progressive supranuclear palsy is considered a Parkinson plus syndrome, and it presents with trap features, just like Parkinson's, but it also includes vertical gaze palsy and cognitive dysfunction. This condition is associated with the so-called hummingbird sign on midbrain MRI, which is a classic imaging clue. Next, let's shift our focus to Huntington's disease, which involves the loss of GABAergic neurons in the striatum. It is inherited in an autosomal dominant fashion, caused by a trinucleotide repeat expansion of the CAG sequence in the Huntingtin gene, located on chromosome 4, and this leads to a toxic gain of function. Symptoms tend to appear between the ages of 30 and 50 and include chorea, athetosis, aggression, depression, and dementia. Early symptoms are sometimes mistaken for substance use disorders. Imaging reveals atrophy of the caudate and putamen, along with ex vacuo ventriculomegaly. Dopamine levels are increased, while GABA and acetylcholine levels are decreased in the brain. Neuronal death results from NMDA receptor binding and glutamatic cytotoxicity. The phenomenon of anticipation, which refers to earlier onset in successive generations, is caused by further expansion of CAG repeats. A helpful way to remember this is, the caudate loses ACH and GABA. Now let's turn to dementia in general, which refers to a decline in cognitive ability such as memory and executive function, while consciousness remains intact. Some causes of dementia are reversible and include depression, which may mimic dementia and is called pseudodementia, as well as hypothyroidism, vitamin B12 deficiency, neurosyphilis, and normal pressure hydrocephalus. Now listen carefully. Alzheimer's disease is the most common cause of dementia in older adults, and the strongest risk factor is advanced age. Patients with Down syndrome are at increased risk of early-onset Alzheimer's disease because the amyloid precursor protein, or AP, is located on chromosome 21. In Alzheimer's disease, acetylcholine levels are reduced in the brain. Several altered proteins are associated with the disease, including APO2, which reduces the risk of the sporadic form, and APO4, which increases that risk. In familial forms, which account for about 10% of cases and have earlier onset, mutations in APP, presenilin 1, and presenilin 2 are involved. A useful mnemonic is, APO2 is proactive, and APO4 is for Alzheimer's disease. Now let's examine the brain changes in Alzheimer's disease. There is widespread cortical atrophy, especially involving the hippocampi, with narrowing of the gyri and widening of the sulci. Senile plaques are found in the gray matter and contain extracellular amyloid beta cores. These may cause amyloid angiopathy, leading to intraparenchymal hemorrhage. Amyloid beta itself is derived from the cleavage of APP. Another key feature is the presence of neurofibrillary tangles, which are intracellular accumulations of hyperphosphorylated tau protein. These form insoluble cytoskeletal elements, and the number of tangles strongly correlates with the degree of dementia. You should also remember the presence of Hirano bodies, which are intracellular eosinophilic, proteinaceous rods found in the hippocampus. Now let's talk about frontotemporal dementia, which was formerly called Pick disease, and it typically begins with early changes in personality and behavior, which defines the behavioral variant, or it may start with aphasia, known as primary progressive aphasia. Patients may also show associated movement disorders. The underlying pathology involves atrophy of the frontal and/or temporal lobes. Microscopic examination reveals inclusions of hyperphosphorylated tau, forming round Pick bodies, or inclusions of ubiquitinated TDP-43. Are you ready to continue? Lewy body dementia is another distinct type of progressive cognitive decline, where patients experience visual hallucinations, sometimes humorously referred to as hallucinations, along with dementia that fluctuates in cognition and alertness, REM sleep behavior disorder, and features of Parkinsonism. The pathological hallmark is the presence of intracellular Lewy bodies, primarily located in the cortex. If the onset of cognitive and motor symptoms occurs within 1 year of each other, the diagnosis is Lewy body dementia. However, if the motor symptoms have been present for more than a year before the cognitive symptoms begin, then it is more appropriate to consider it as dementia secondary to Parkinson's disease. Listen carefully, vascular dementia is the second most common cause of dementia in older adults. It results from multiple arterial infarcts or chronic ischemia that damage the brain over time. The clinical course is typically marked by a stepwise decline in cognitive function, rather than a gradual progression, and memory impairment appears later. Neuroimaging with MRI or CT often shows multiple cortical and/or subcortical infarcts. Let's now shift to Creutzfeldt-Jakob disease, a rapidly progressive dementia that worsens over weeks to months and is marked by the presence of myoclonus, especially startle myoclonus, and ataxia. This condition is invariably fatal and is caused by prion, in which the normal cellular prion protein, called PRPC, is converted into the abnormal, disease-associated isoform PRPSC, which has a beta-pleated sheet configuration and is resistant to proteases. Although typically sporadic, it can be transmitted through contaminated materials, such as corneal transplants or improperly sterilized neurosurgical equipment. Brain tissue shows spongiform cortex, with vacuolation but no inflammation. Supporting findings include periodic sharp wave complexes on EEG and elevated 14-3-3 protein in the CSF. And finally, let's talk about HIV-associated dementia, which emerges in advanced stages of HIV infection and is classified as a subcortical dysfunction. It is characterized by a range of symptoms, including cognitive deficits, gait disturbances, irritability, and a depressed mood. Imaging often reveals diffuse gray matter and subcortical atrophy. Pathologically, you'll find microglial nodules that contain multinucleated giant cells. Have you heard about idiopathic intracranial hypertension, which is also known as pseudotumor cerebri? This condition involves increased intracranial pressure without any obvious structural findings on imaging. It primarily affects women and is associated with several risk factors, including the use of tetracyclines, obesity, vitamin A excess, and the drug danazol. You can remember this combination with the mnemonic, female toad. The condition is also associated with dural venous sinus stenosis. Clinical findings include headache that worsens when lying down, tinnitus, and diplopia, usually resulting from cranial nerve 6 palsy. Importantly, there is no change in mental status. The elevated pressure impairs axoplasmic flow in the optic nerve, leading to papilledema. Visual field testing often reveals an enlarged blind spot along with peripheral constriction. When a lumbar puncture is performed, it shows increased opening pressure and may provide temporary relief of the headache. Are you ready to continue? Treatment begins with weight loss and administration of acetazolamide, and for refractory cases, especially those involving vision loss, more invasive measures may be necessary. These include cerebrospinal fluid shunt placement or optic nerve sheath fenestration surgery. Now let's talk about hydrocephalus, which is defined as an increase in cerebrospinal fluid volume, leading to dilation of the ventricles and, in some cases, increased intracranial pressure. It can be divided into several types, each with different causes and imaging findings. Let's begin with communicating hydrocephalus, where there is decreased absorption of CSF by the arachnoid granulations. This is often due to arachnoid scarring following meningitis. The result is increased intracranial pressure, papilledema, and the potential for herniation. On imaging, you'll see that all the ventricles are dilated. Now listen carefully, normal pressure hydrocephalus typically affects older adults and is often idiopathic. In this condition, CSF pressure is elevated only episodically, and it does not result in an increase in subarachnoid space volume. What happens instead is that the ventricles expand, which distorts the fibers of the corona radiata. This leads to a classic triad of symptoms: gait apraxia, also known as magnetic gait, cognitive dysfunction, and urinary incontinence. This triad is often remembered as wobbly, wacky, and wet. Treatment involves cerebrospinal fluid drainage via lumbar puncture or shunt placement, which can result in significant clinical improvement. Let's now examine non-communicating hydrocephalus, also known as obstructive hydrocephalus. This type results from a structural blockage in the flow of cerebrospinal fluid within the ventricular system. Common causes include stenosis of the aqueduct of Sylvius, a colloid cyst blocking the foramen of Monro, or a tumor obstructing CSF flow. In this scenario, only the ventricles located upstream of the obstruction become dilated, and the pattern of ventricular enlargement depends on the level of the blockage. And finally, we'll discuss hydrocephalus mimics, specifically, ex vacuo ventriculomegaly. In this condition, imaging shows an apparent increase in CSF, but this is not due to actual overproduction or obstruction. Instead, it's a result of brain tissue loss and neuronal atrophy. Conditions such as Alzheimer's disease, HIV, frontotemporal dementia, and Huntington disease can lead to this appearance. Importantly, intracranial pressure remains normal, and the triad seen in normal pressure hydrocephalus does not occur in these patients. Let's talk about multiple sclerosis, which is an autoimmune condition involving inflammation and demyelination of the central nervous system, affecting both the brain and spinal cord, and ultimately leading to axonal damage. It most commonly affects females between the ages of 20 and 40, and there is a higher prevalence among individuals who spent their early years farther from the equator, often associated with reduced serum vitamin D levels. Clinically, it can present in many ways, and these include optic neuritis, which causes acute, painful, monocular visual loss and is typically associated with a relative afferent pupillary defect. Other manifestations can arise from brainstem or cerebellar syndromes, such as diplopia, ataxia, vertigo, scanning speech, dysarthria, intention tremor, and nystagmus, as well as intranuclear ophthalmoplegia, more commonly bilateral than unilateral. Now listen carefully. Pyramidal tract demyelination may cause symptoms like weakness and spasticity, while spinal cord syndromes can include an electric shock-like sensation that starts with cervical flexion and transmits down the spinal cord, known as the Lermite sign. Additional signs include neurogenic bladder, paraparesis, and sensory changes that may affect the trunk or one or more extremities. These symptoms can be exacerbated by various stressors, such as heat, referred to as the Uthoff phenomenon, as well as exercise or infections. The most common clinical course of multiple sclerosis is relapsing and remitting, with intervals of improvement followed by new or worsening symptoms. Are you following me? Diagnostic findings include increased immunoglobulin G levels and elevated myelin basic protein in the cerebrospinal fluid. The presence of oligoclonal bands in the CSF is particularly helpful for diagnosis. The gold standard imaging tool is MRI, which typically shows periventricular plaques. These are areas where oligodendrocytes are lost, and reactive gliosis occurs. Multiple white matter lesions that are disseminated both in space and time help confirm the diagnosis and differentiate it from other conditions. Now let's discuss the treatment, which focuses on stopping relapses and slowing or halting disease progression through disease-modifying therapies. These include beta-interferon, glatiramer acetate, and natalizumab. Acute flares are managed with intravenous steroids to reduce inflammation and relieve symptoms. Symptomatic treatment also plays an important role. Neurogenic bladder may be managed using muscarinic antagonists or botulinum toxin injections, while spasticity is commonly treated with baclofen, a GABA receptor agonist. Pain, which can be chronic and distressing, may be treated using tricyclic antidepressants or anticonvulsants depending on the patient's needs. Now listen carefully to these categorized manifestations. Neurologically, patients may experience fatigue, depression, ataxia, and intention tremor. Ophthalmic findings include optic neuritis, diplopia, nystagmus, and internuclear ophthalmoplegia. In terms of spinal cord involvement, there may be sensory symptoms, weakness, and spasticity. Speech symptoms often involve dysarthria and scanning speech, while urinary involvement is typically in the form of incontinence. Let's talk about other demyelinating and dysmyelinating disorders, starting with osmotic demyelination syndrome, also known as central pontine myelinolysis. This condition involves massive axonal demyelination within the pontine white matter, and it is secondary to rapid osmotic changes, most commonly from iatrogenic correction of hyponatremia, though it can also result from abrupt shifts in other osmolytes like glucose. Clinically, it presents with acute paralysis, dysarthria, dysphagia, diplopia, and loss of consciousness. It can lead to an altered level of consciousness and requires careful sodium management. You should remember these critical mnemonics: from low to high, your pons will die, referring to osmotic demyelination syndrome, and, from high to low, your brains will blow, which highlights the risk of cerebral edema or herniation when sodium is corrected too quickly in the opposite direction. Now listen carefully to the most common subtype of Guillain-Barré syndrome, which is called acute inflammatory demyelinating polyneuropathy. It is an autoimmune condition where Schwann cells are destroyed due to inflammation and demyelination affecting motor fibers, sensory fibers, and peripheral nerves, including cranial nerves from 3 to 12. This disorder is often facilitated by molecular mimicry and can be triggered by inoculations or physical stress, and although frequently associated with infections like Campylobacter jejuni or viruses such as Zika, there is no definitive causal link to any single pathogen. The hallmark presentation is symmetric ascending muscle weakness or paralysis, accompanied by depressed or absent deep tendon reflexes starting in the lower limbs. Bilateral facial paralysis and respiratory failure are common and serious complications, and autonomic disturbances like cardiac irregularities or blood pressure fluctuations may occur, along with sensory abnormalities. Most patients recover well with proper care. In this condition, the cerebrospinal fluid shows elevated protein levels but a normal cell count, a pattern called albuminocytologic dissociation. Respiratory support is absolutely critical until the patient begins to recover. The recommended disease-modifying treatments include plasma exchange and intravenous immunoglobulins, while steroids do not play a role in the management of this condition. Now let's move to acute disseminated encephalomyelitis, also known as post-infectious encephalomyelitis. This disorder is characterized by multifocal inflammation and demyelination following infection or vaccination. The symptoms develop rapidly and may involve multiple neurologic areas along with altered mental status. Let's explore Charcot-Marie-Tooth disease, also referred to as hereditary motor and sensory neuropathy. This is a group of progressive hereditary nerve disorders resulting from defective production of proteins vital to the structure and function of peripheral nerves or the myelin sheath. It is typically inherited in an autosomal dominant fashion and presents with foot deformities such as pes cavus or hammer toe, along with lower extremity weakness like foot drop and sensory deficits, particularly in vibration and proprioception. The most common type is CMT1A, which is caused by a duplication of the PMP22 gene, and you might remember it with the phrase, "can't move toes." Are you ready for the next one? Progressive multifocal leukoencephalopathy is a rapidly progressive and usually fatal condition involving CNS demyelination due to the destruction of oligodendrocytes, which occurs following reactivation of latent JC virus infection. This condition is closely associated with severe immunosuppression, such as in lymphomas, leukemias, AIDS, or after organ transplantation. It typically involves the parietal and occipital lobes, so visual symptoms are common, and the risk is especially increased with medications like natalizumab, often used in autoimmune conditions. Now listen carefully to critical illness polyneuropathy, which results from axonal degeneration, likely driven by inflammatory mediators and microcirculatory injury. This leads to reduced nerve excitability due to sodium channel inactivation, causing symmetric weakness that is more pronounced proximally than distally. Deep tendon reflexes are diminished, and diaphragmatic weakness may impair the patient's ability to wean from mechanical ventilation, making it a serious complication in intensive care settings. Finally, let's not forget the other important dysmyelinating disorders such as Krabbe disease, metachromatic leukodystrophy, and adrenoleukodystrophy, each contributing unique genetic and metabolic factors to the broader landscape of myelin-related diseases. Let's dive into the neurocutaneous disorders, beginning with Sturge-Weber syndrome, which is a congenital, non-hereditary anomaly involving neural crest derivatives. This condition arises from somatic mosaicism of an activating mutation in one copy of the GNAQ gene, and its clinical presentation includes a capillary vascular malformation known as a port wine stain, also called a nevus flammeus or a non-neoplastic birthmark, typically distributed over the territory of cranial nerves V1 and V2. On the same side, there's often an associated leptomeningeal angioma, which may exhibit calcifications and lead to seizures or epilepsy, and the condition may also present with intellectual disability. Furthermore, episcleral hemangioma is frequently seen, which contributes to increased intraocular pressure and can cause early-onset glaucoma. This entire constellation is referred to as encephalotrigeminal angiomatosis. Next is tuberous sclerosis complex, which follows an autosomal dominant inheritance pattern and demonstrates variable expression. It results from mutations in tumor suppressor genes, either TSC1 located on chromosome 9, which codes for hamartin, or TSC2 found on chromosome 16, which codes for tuberin, and yes, that's pronounced tuberin. Clinically, this disorder features hamartomas in both the central nervous system and the skin, along with angiofibromas, mitral regurgitation, ashleaf spots, cardiac rhabdomyoma, intellectual disability, renal angiomyolipoma, seizures, and Sjagren patches. There is also an increased incidence of subependymal giant cell astrocytomas and ungual fibromas, making it a multisystemic and complex disorder. Neurofibromatosis type 1, which is autosomal dominant and shows 100% penetrance. It is caused by a mutation in the NF1 tumor suppressor gene located on chromosome 17, which encodes neurofibromin, a negative regulator of the RAS pathway. The condition is characterized by café au lait spots, intellectual disability, cutaneous neurofibromas, Lisch nodules, which are pigmented iris hamartomas, optic gliomas, pheochromocytomas, seizures or focal neurologic signs, often resulting from meningiomas, and bone lesions such as sphenoid dysplasia. This disorder is also known as von Recklinghausen disease, and a helpful mnemonic is that there are 17 letters in von Recklinghausen, just like the chromosome it's linked to. The features can be remembered using cyclops. Are you ready for the next one? Neurofibromatosis type 2 is also autosomal dominant, but it involves a mutation in the NF2 tumor suppressor gene, which encodes Merlin and is located on chromosome 22. The hallmark features include bilateral vestibular schwannomas, juvenile cataracts, meningiomas, and ependymomas. A simple way to remember this is that NF2 affects 2 ears and 2 eyes, matching the gene's position on chromosome 22. Now let's talk about von Hippel-Lindau disease, another autosomal dominant condition caused by a deletion of the VHL gene on chromosome 3p. The protein product, PVHL, functions to ubiquitinate hypoxia-inducible factor 1 alpha, thereby playing a crucial role in regulating cell growth. Clinically, this disease presents with hemangioblastomas, which are highly vascular tumors with hyperchromatic nuclei, typically occurring in the retina, brainstem, cerebellum, and spine. There is also angiomatosis, bilateral renal cell carcinomas, and pheochromocytoma. The HARP mnemonic helps recall these features: hemangioblastomas, angiomatosis, renal cell carcinomas, and pheochromocytoma. This disease involves numerous tumors, both benign and malignant. And remember, VHL has 3 letters, it's located on chromosome 3, and it's associated with RCC, another 3-letter abbreviation. Let's talk about adult primary brain tumors, beginning with glioblastoma, which is a common and highly malignant primary brain tumor, characterized by a median survival of about 1 year. It typically arises in the cerebral hemispheres and is known for its ability to cross the corpus callosum, forming what is famously called a butterfly glioma. This tumor is associated with EGFR amplification and originates from astrocytes. It is GFAP positive, and histologically, it displays pseudopalisading, pleomorphic tumor cells that border central areas of necrosis, hemorrhage, and microvascular proliferation. These features contribute to its aggressive nature and poor prognosis. Now listen carefully as we move to oligodendroglioma, which is relatively rare and slow-growing. It is most often found in the frontal lobes and frequently exhibits calcification. This tumor arises from oligodendrocytes and is characterized histologically by fried egg cells, meaning round nuclei with clear cytoplasm. Another key feature is the distinctive chicken wire capillary pattern that we see under the microscope, highlighting the tumor's vascular structure and aiding in its diagnosis. Are you following me? Because next is meningioma, a common and typically benign tumor that affects females more than males. It occurs along the surface of the brain or spinal cord and is classified as extraaxial, meaning it lies external to the brain parenchyma. It often presents with a dural attachment, giving rise to the so-called tail appearance. Meningiomas are usually well circumscribed and may be spherical or lobular in shape. Although often asymptomatic, they may cause seizures or focal neurologic signs. The treatment generally involves surgical resection and sometimes radiosurgery. Histologically, these tumors arise from arachnoid cells and feature spindle cells arranged in a whorled pattern, often accompanied by psammoma bodies, which are laminated calcifications. Now let's turn to hemangioblastoma, which is most commonly found in the cerebellum and is associated with von Hippel-Lindau syndrome, especially when it coexists with retinal angiomas. These tumors can produce erythropoietin, leading to secondary polycythemia. They originate from blood vessels and are characterized histologically by closely arranged, thin-walled capillaries with minimal intervening parenchyma. Their high vascularity and distinct cellular makeup make them a notable feature of the VHL disease spectrum. Are you ready for more? Let's explore pituitary adenomas, which may be non-functioning or hyperfunctioning. Non-functional tumors often present due to mass effect, such as bitemporal hemianopia, caused by compression of the optic chiasm. In cases of pituitary apoplexy, there may be resulting hypopituitarism. Prolactinomas, which are the most common type, typically present with galactorrhea, amenorrhea, and decreased bone density in females due to suppressed estrogen, and in males, they can cause decreased libido and infertility. Treatment options include dopamine agonists like bromocriptine or cabergoline, or surgical transphenydoidal resection. These tumors result from hyperplasia of only one type of endocrine cell in the pituitary, most commonly the lactotrophs that produce prolactin, leading to hyperprolactinemia. Less commonly, they may arise from somatotrophs producing growth hormone, causing acromegaly or gigantism, from corticotrophs producing ACTH, resulting in Cushing disease, and rarely from thyrotrophs or gonadotrophs. Now listen closely as we conclude with schwannomas, which classically occur at the cerebellopontine angle and are benign tumors involving cranial nerves 5, 7, and 8, though they may arise along any peripheral nerve. They are often localized to cranial nerve 8 within the internal acoustic meatus, leading to vestibular schwannomas that may present with hearing loss, tinnitus, and unsteady gait. In patients with neurofibromatosis type 2, bilateral vestibular schwannomas are a key feature. Treatment usually involves surgical resection or stereotactic radiosurgery. These tumors are derived from Schwann cells and are S100 positive. Histologically, they exhibit a biphasic pattern with dense, hypercellular areas containing spindle cells, alternating with hypocellular, myxoid regions. We reach discussion of childhood primary brain tumors, starting with pilocytic astrocytoma, which is the most common primary brain tumor in children. It is usually well circumscribed and, in pediatric cases, most often found in the posterior fossa, especially the cerebellum, although it may also appear supratentorially. The tumor often has a cystic appearance with a mural nodule, and despite being a neoplasm, it is considered benign with a good prognosis. Histologically, it originates from astrocytes and is GFAP positive. The tumor features bipolar neoplastic cells that have hair-like projections, along with microcysts and Rosenthal fibers, which are eosinophilic, corkscrew-shaped fibers commonly seen in this tumor type. Next is medulloblastoma, which holds the distinction of being the most common malignant brain tumor in childhood. It commonly affects the cerebellum and, when it involves the cerebellar vermis, it may cause truncal ataxia. This tumor can compress the fourth ventricle, leading to non-communicating hydrocephalus, which then results in headaches and papilledema. A notable characteristic of medulloblastoma is its potential to send, drop metastases, to the spinal cord. Histologically, this tumor is a form of primitive neuroectodermal tumor, or PNET, and it exhibits homocyte rosettes, composed of small, round, blue cells arranged around a central area of neuropil. It is also positive for synaptophysin, which helps confirm the diagnosis. Let's talk about ependymoma, which is most commonly located in the fourth ventricle and can similarly lead to non-communicating hydrocephalus, just like medulloblastoma. Unfortunately, ependymomas tend to carry a poor prognosis. These tumors originate from ependymal cells and are histologically defined by their characteristic perivascular pseudorosets. In addition, rod-shaped blepharoplasts, which are basal ciliary bodies, can be found near the nucleus, giving additional clues under microscopic examination. Are you ready to continue? Because next is craniopharyngioma, which is the most common childhood tumor located in the supratentorial region. Calcification within this tumor is quite common, and it typically arises along the pituitary stalk. This location often leads to compression of the optic chiasm, resulting in bitemporal hemianopia, a presentation that may sometimes be confused with that of a pituitary adenoma. Craniopharyngiomas are associated with a high recurrence rate. These tumors are derived from remnants of Rathke's pouch, which is of ectodermal origin. Histologically, they contain anucleate squamous cells, often called ghost cells, which form keratinous nodules with dystrophic calcifications. Additionally, cholesterol crystals are often found suspended in a motor oil-like fluid within the tumor. Listen closely as we conclude with pineal gland tumors, which are most commonly extragonadal germ cell tumors and show an increased incidence in males. These tumors typically present with non-communicating hydrocephalus due to compression of the cerebral aqueduct, and may also cause Parano syndrome, which results from compression of the dorsal midbrain. This syndrome includes a triad of upward gaze palsy, convergence retraction nystagmus, and light near dissociation. Histologically and behaviorally, these tumors are similar to testicular seminomas, reflecting their germ cell origin and aggressive potential. Now listen carefully as we explore herniation syndromes, starting with cingulate, also called subfalcine herniation, which occurs when brain tissue shifts under the falx cerebri. This displacement can compress the anterior cerebral artery, which may lead to contralateral lower extremity weakness. And if the dominant hemisphere is involved, the arcuate fasciculus may be compressed, resulting in aphasia. Next is central or downward transtentorial herniation, where there is a caudal displacement of the brainstem. This dangerous movement can cause rupture of paramedian branches of the basilar artery, leading to what are called Durant hemorrhages. These hemorrhages occur in the midbrain and upper pons and are usually fatal. Now let's talk about uncal transtentorial herniation, which involves the uncus, or the medial part of the temporal lobe. In early stages, herniation of the uncus can compress cranial nerve 3 on the ipsilateral side, causing a blown pupil, and also cause contralateral hemiparesis due to pressure on the cerebral peduncle. But as herniation progresses, it can lead to coma, and interestingly, sometimes a misleading clinical sign known as Kernahan's phenomenon can appear, where the contralateral cerebral peduncle is compressed against the tentorial edge, producing ipsilateral hemiparesis and sometimes even a contralateral blown pupil. This can confuse localization, so clinical vigilance is critical. Now listen closely as we come to cerebellar tonsillar herniation into the foramen magnum, a particularly devastating condition. This type of herniation pushes the cerebellar tonsils through the foramen magnum and leads to compression of the medulla. Since the medulla contains vital centers for respiration and cardiovascular regulation, the result is often coma and death if not rapidly addressed. Are you ready for the next topic? Because now we move on to motor neuron signs and how they differ between upper and lower motor neuron lesions. In both types, weakness is present, but in lower motor neuron lesions, everything is lowered. This includes decreased muscle mass, tone, reflexes, and downward pointing of toes. Meanwhile, in upper motor neuron lesions, everything goes up. You'll see increased tone, exaggerated reflexes, and upward toe responses like a positive Babinski sign. Fasciculations, which are brief, involuntary muscle twitches, are seen only in lower motor neuron lesions and are a hallmark sign. Atrophy is also a key feature of lower motor neuron damage, while it is absent in upper motor neuron injuries. Now let's summarize that with careful rhythm, weakness is found in both lesion types, but atrophy and fasciculations are exclusive to lower motor neuron lesions. Reflexes and tone are increased in upper motor neuron lesions but decreased in lower motor neuron conditions. A positive Babinski reflex, which is normal in infants, signals upper motor neuron dysfunction in adults. Spastic paresis and clasp knife spasticity are also specific to upper motor neuron lesions, while flaccid paralysis points to a lower motor neuron source. Now let's talk about spinal cord lesions, beginning with poliomyelitis, a viral condition where the anterior horns are destroyed by poliovirus. It spreads through fecal-oral transmission, replicates in the lymphoid tissue of the oropharynx and small intestine, and then enters the central nervous system via the bloodstream. The hallmark is acute lower motor neuron signs such as asymmetric weakness, and it also presents with symptoms of viral meningitis, including fever, headache, and neck stiffness. If respiratory muscles are involved, respiratory failure can follow. In cerebrospinal fluid, you'll find increased white blood cells indicating lymphocytic pleocytosis, with a slight rise in protein, but no change in glucose levels. And importantly, poliovirus can be isolated from either stool or throat secretions. Now listen carefully, because spinal muscular atrophy also targets the anterior horns, but it's a congenital condition. It arises due to an autosomal recessive mutation in the SMN1 gene, which encodes the survival motor neuron protein. This defect disrupts snRNP assembly, leading to apoptosis of lower motor neurons. The most common form is spinal muscular atrophy type 1, also known as Verdnig-Hoffmann disease. It presents with only lower motor neuron signs, there is symmetric weakness, and affected infants appear as floppy babies, with marked hypotonia and tongue fasciculations. This condition exemplifies pure lower motor neuron degeneration from birth. Let's fucking discuss amyotrophic lateral sclerosis, also known as ALS or Lou Gehrig disease, which involves both upper and lower motor neuron degeneration. It typically arises idiopathically, but in familial cases, mutations in the SOD1 gene, which encodes superoxide dismutase 1, may be implicated. The lower motor neuron signs include flaccid limb weakness, fasciculations, atrophy, and bulbar palsy, which manifests as dysarthria, dysphagia, and tongue atrophy. Upper motor neuron signs appear as spastic limb weakness, hyperreflexia, clonus, and pseudobulbar palsy, including dysarthria, dysphagia, and emotional lability. Notably, ALS spares sensory function and bowel or bladder control. The disease is fatal, usually from respiratory failure. Treatment involves riluzole and edaravone, which help slow functional decline. Now listen motherfuckers as we explore tabes dorsalis, a condition caused by degeneration or demyelination of the dorsal columns and roots due to Treponema pallidum, the agent of tertiary syphilis. This leads to progressive sensory ataxia, resulting from impaired proprioception and poor coordination. The Romberg sign is positive, and deep tendon reflexes are absent. Associated features include sharp, shooting pain, Argyll-Robertson pupils, and Charcot joints. Let's move on to subacute combined degeneration, which results from vitamin B12 deficiency. This deficiency causes demyelination of the spinocerebellar tracts, lateral corticospinal tracts, and dorsal columns, hence the name SCD. Clinically, it presents with an ataxic gait, paresthesias, and impaired position and vibration sense, again with a positive Romberg sign. Upper motor neuron signs are also present, distinguishing it from pure sensory disorders. It's crucial to diagnose and treat this early to prevent irreversible spinal cord damage. Finally, let's discuss anterior spinal artery occlusion, a serious cause of spinal cord infarction. This condition typically spares the dorsal horns and dorsal columns but affects other regions supplied by the anterior spinal artery. The mid-thoracic region is a watershed zone, particularly vulnerable because it lies above the area where the artery of Adamkiewicz supplies blood below T8. A common cause is aortic aneurysm repair, which can interrupt this critical blood flow. Patients will present with upper motor neuron signs below the lesion due to corticospinal tract involvement, and lower motor neuron signs at the level of the lesion due to damage to the anterior horn. Listen carefully, Brown-Sequard syndrome results from a hemisection of the spinal cord, and the findings depend on which tracts and sensory pathways are affected. At the level of the lesion, there's an ipsilateral loss of all sensation, involving all sensory pathways, and ipsilateral lower motor neuron signs, like flaccid paralysis, due to corticospinal tract damage. Below the lesion, the same corticospinal tract causes ipsilateral upper motor neuron signs. The dorsal columns are also affected, leading to ipsilateral loss of proprioception, vibration, and fine touch, such as two-point discrimination, below the level of the lesion. But here's the key part: damage to the spinothalamic tract results in contralateral loss of pain, temperature, and crude touch below the lesion. And if the lesion occurs above T1, the oculosympathetic pathway may be involved, resulting in ipsilateral Horner syndrome. Let's shift gears to Friedreich ataxia, which is an autosomal recessive disorder caused by a trinucleotide repeat, GAA, on chromosome 9, in the gene that encodes frataxin, an iron-binding protein. This defect impairs mitochondrial functioning, and degeneration occurs in multiple regions, including the lateral corticospinal tract, causing spastic paralysis, the spinocerebellar tract, causing ataxia, the dorsal columns, leading to reduced vibratory sense and proprioception, and the dorsal root ganglia, resulting in loss of deep tendon reflexes. Clinically, you'll see staggering gait, frequent falls, nystagmus, dysarthria, pes cavus, and hammer toes. Importantly, it's associated with diabetes mellitus and hypertrophic cardiomyopathy, which is the most common cause of death. This condition presents in childhood, and kyphoscoliosis is often observed. Just remember the phrase, Friedreich is fratastic, your favorite frat brother who's always staggering and falling, but has a sweet, big heart, and an ataxic GA8. Now let's move on to cerebral palsy, a condition defined by permanent motor dysfunction resulting from non-progressive injury to the developing fetal or infant brain. It stands as the most common movement disorder in children. The etiology is multifactorial, but the strongest risk factors include prematurity and low birth weight. A key pathological feature is the development of periventricular leukomalacia, which is focal necrosis of the white matter tracts. Clinically, you'll see upper motor neuron signs such as spasticity and hyperreflexia, affecting one or more limbs. There's also persistence of primitive reflexes, abnormal posture, delayed development in motor skills, and neurobehavioral abnormalities, which may manifest as either excessive docility or irritability. For treatment, muscle relaxants like baclofen are used, as well as botulinum toxin injections and selective dorsal rhizotomy. And for prevention, prenatal magnesium sulfate in high-risk pregnancies has been shown to reduce both the incidence and the severity of cerebral palsy. Listen carefully, when it comes to common cranial nerve lesions, let's start with the cranial nerve 5 motor lesion, where the jaw deviates toward the side of the lesion because of unopposed force from the opposite pterygoid muscle. In a cranial nerve 10 lesion, the uvula deviates away from the side of the lesion, the weak side collapses, and the uvula points in the opposite direction. When you have a cranial nerve 11 lesion, there is weakness when turning the head away from the side of the lesion due to the sternocleidomastoid, and you'll also notice shoulder droop on the side of the lesion because of trapezius involvement. Finally, in a cranial nerve 12 lesion, which is a lower motor neuron lesion, the tongue deviates toward the side of the lesion, so remember the phrase, lick your wounds, because of weakened tongue muscles on the affected side. Let's talk about facial nerve lesions, starting with Bell palsy, which is the most common cause of peripheral facial palsy. This condition usually develops after herpes simplex virus reactivation. For treatment, glucocorticoids are used, sometimes combined with acyclovir. Most patients gradually recover function over time, but aberrant regeneration can happen. Other causes of peripheral facial palsy include Lyme disease, herpes zoster, also known as Ramsay-Hunt syndrome, which presents with a triad of ipsilateral facial paralysis, otalgia, and vesicles near the auditory canal, plus conditions like sarcoidosis, tumors such as parotid gland tumors, and diabetes mellitus. Let's compare upper and lower motor neuron lesions of the facial nerve. An upper motor neuron lesion is located in the motor cortex, or in the connection from the motor cortex to the facial nucleus in the pons. In contrast, a lower motor neuron lesion affects the facial nucleus or any part of the facial nerve, CN7. The affected side is contralateral in upper motor neuron lesions and ipsilateral in lower motor neuron lesions. The muscles involved also differ. In UMN lesions, only the lower muscles of facial expression are affected, while in LMN lesions, both upper and lower muscles are involved. One key point, you should remember this, is that in UMN lesions, the forehead is spared due to bilateral upper motor neuron innervation, but in LMN lesions, the forehead is affected. Now listen carefully, in lower motor neuron lesions, you may also see incomplete eye closure, which can lead to dry eyes or even corneal ulceration. Patients may experience hyperacusis, which is increased sensitivity to sound, and loss of taste sensation from the anterior part of the tongue. The face area of the motor cortex is divided into upper and lower divisions, and these connect to the facial nucleus. So, whether the lesion is central, affecting the corticobulbar tract, or peripheral, affecting the facial nerve itself, the clinical pattern will differ significantly, and understanding this distinction is crucial for accurate localization and diagnosis. Special sense organs. First is otology. Let's start with auditory anatomy and physiology, beginning with the outer ear, which is the visible portion of the ear called the pinna. This includes the auditory canal and the tympanic membrane. Its primary role is to transfer sound waves by vibrating the tympanic membrane. Moving inward to the middle ear, this is an air-filled space that contains three tiny bones known as the ossicles, which are the malleus, incus, and stapes. These bones work together to conduct and amplify sound vibrations from the tympanic membrane all the way to the inner ear. And now, the inner ear itself is a snail-shaped, fluid-filled structure called the cochlea. Inside, you'll find the basilar membrane, which vibrates in response to sound waves. These vibrations are transduced through specialized hair cells, leading to signaling along the auditory nerve, and eventually to the brainstem. Are you following me? Each frequency of sound causes vibration at a specific location on the basilar membrane, a concept known as tonotopy. Low-frequency sounds are heard at the apex near the helicotrema, where the membrane is wide and flexible. In contrast, high-frequency sounds are heard best at the base of the cochlea, where the membrane is thin and rigid. This frequency-specific mapping is critical for our perception of pitch and tone. Now listen carefully, let's move on to otitis externa, which is inflammation of the external auditory canal. It is most commonly caused by Pseudomonas and is frequently associated with water exposure, hence the name swimmer's ear, as well as ear canal trauma or occlusion, for example, due to hearing aids. It typically presents with otalgia that gets worse with manipulation of the ear, along with pruritus, hearing loss, and discharge. A severe form, called malignant or necrotizing otitis externa, is an invasive infection that causes osteomyelitis, and it is mostly seen in older adults with diabetes. These patients present with severe otalgia and otorrhea, and may develop cranial nerve palsies. On physical exam, one may see granulation tissue within the ear canal. Now let's talk about otitis media, which is the inflammation of the middle ear. The most common pathogens include non-typable Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. This condition is often linked to eustachian tube dysfunction, which allows bacteria from the upper respiratory tract to overgrow and cause infection. Otitis media usually affects children under 2 years old, and presents with fever, otalgia, and hearing loss. Upon examination, you'll often find a bulging, erythematous tympanic membrane, which may even rupture in some cases. Are you ready for the complications? One serious complication of acute otitis media is mastoiditis, which is the infection of the mastoid process of the temporal bone. This happens because of the anatomical continuity between the middle ear cavity and the mastoid air cells. Clinically, it presents with postauricular pain, erythema, and swelling, and it may progress to serious issues like brain abscess if not treated promptly and properly. The common causes of hearing loss, beginning with noise-induced hearing loss, which results from damage to the stereociliated cells in the organ of Corti. This damage leads to a loss of high-frequency hearing first, and in more extreme cases, sudden, extremely loud noises can rupture the tympanic membrane, leading to immediate and severe hearing loss. Next is presbycusis, which is an aging-related, progressive, bilateral, and symmetric form of sensorineural hearing loss, that most often affects higher frequencies. This happens because of the gradual destruction of hair cells at the cochlear base, although low-frequency hearing is preserved at the apex of the cochlea. When it comes to diagnosing hearing loss, we rely on two standard bedside tests, the Weber test and the Rinne test. In a normal Weber test, when a tuning fork is placed on the vertex of the skull, the sound is heard equally in both ears, meaning there is no localization. For the Rinne test, we compare air conduction by holding the fork in front of the ear, and bone conduction by placing it on the mastoid process. In a normal ear, air conduction is greater than bone conduction, or AC greater than BC. However, in conductive hearing loss, the Weber test localizes to the affected ear, because background noise is reduced, and bone conduction becomes greater than air conduction, or BC greater than AC. In sensorineural hearing loss, the Weber test localizes to the unaffected ear, due to a reduction in all sound transmission, while air conduction still remains greater than bone conduction, that is, AC greater than BC. Now we turn to cholesteatoma, which refers to the abnormal growth of keratinized squamous epithelium in the middle ear, often described as skin in the wrong place. While it can be congenital, it is usually acquired, and the primary acquired form results from tympanic membrane retraction pockets that develop due to eustachian tube dysfunction. The secondary acquired form follows tympanic membrane perforation, such as that caused by otitis media, allowing squamous epithelium to migrate into the middle ear. The classic presentation includes painless otorrhea, and if it progresses, it can erode the ossicles, leading to conductive hearing loss. Let's explore vertigo, which is the false sensation of spinning while you are actually stationary. It's a specific subtype of dizziness and should not be confused with lightheadedness. Most cases of vertigo are peripheral in origin. Peripheral vertigo results from problems in the inner ear, and includes conditions like vestibular neuritis, or benign paroxysmal positional vertigo, BPPV, which is caused by semicircular canal debris. This condition triggers episodic vertigo lasting less than or equal to 1 minute, and it's often provoked by specific head movements. It can be diagnosed using the Dix-Hallpike maneuver and is treated with the Epley maneuver. Another cause is Meniere disease, which involves endolymphatic hydrops, or an increase in endolymph volume in the inner ear, and presents with a triad of vertigo, sensorineural hearing loss, and tinnitus. Think of it like this: men wear vests. On examination, you'll find mixed horizontal torsional nystagmus, which is never purely torsional or vertical, and it is suppressible with visual fixation. Now listen closely, because central vertigo is different. It arises from brainstem or cerebellar lesions, such as a stroke affecting the vestibular nuclei, demyelinating diseases, or a posterior fossa tumor. Unlike peripheral vertigo, the nystagmus here can be in any direction, and it is not suppressible with visual fixation. These patients often exhibit additional neurologic findings, including diplopia, ataxia, or dysmetria, making it essential to distinguish this from peripheral causes for proper diagnosis and management. The normal anatomy of the eye. The optic nerve carries visual information to the brain, while the ciliary body, which is located in the middle layer of the eye anteriorly, plays a key role in producing aqueous humor and controlling the shape of the lens through zonular fibers. The lens, found just behind the iris, focuses light onto the retina, and it separates the anterior chamber, which lies between the cornea and the iris, from the posterior chamber, located between the iris and the lens. The sclera, which forms the outer protective coat of the eye, then there is choroid, which is vascular middle layer that nourishes the retina, inner layer is the retina, where photoreceptors reside. Deep in the retina is the fovea, the central point of sharpest vision. Are you following me? The eye is also divided into segments. The anterior segment includes both the anterior chamber and the posterior chamber, whereas the posterior segment refers to everything behind the lens, such as the vitreous chamber. The central retinal artery and central retinal vein enter at the back of the eye and are surrounded optic nerve A. Light first passes through the cornea, the clear outer surface, then through the iris, the pigmented structure that controls pupil size, then through lens. The optic disc is where the optic nerve exits the eye, and nearby lies the macula, which houses the fovea, the center of high acuity vision. The retinal artery and retinal vein also branch across the retinal surface, and the normal optic cup appears as a small, central depression within the optic disc. Now listen carefully as we move to conjunctivitis, which is inflammation of the conjunctiva, and it leads to a red eye. It may present in several forms. The allergic type typically causes itchy eyes and is bilateral. The bacterial type produces purulent discharge, and it is treated with antibiotics. The viral form is the most common, often caused by adenovirus, and features sparse mucus discharge, a swollen preauricular node, and increased lacrimation, and it is generally self-resolving. In neonates, conjunctivitis appears with eyelid swelling and exudative discharge following vaginal birth, and diagnosis involves NAAT to identify bacterial pathogens. Maternal prenatal screening and treatment can reduce its occurrence significantly. Now let's talk more about neonatal conjunctivitis. The most common cause is chlamydia trachomatis, specifically serotypes D through K, with symptoms starting between 5 to 14 days after birth. This is treated with erythromycin or azithromycin. Another important pathogen is Neisseria gonorrhoeae, which usually appears between 2 to 5 days after birth, and is prevented using erythromycin eye drops, and treated with ceftriaxone to prevent blindness. Other possible causes include herpes simplex virus and adenovirus, though they are less common. Now listen closely as we move on to refractive errors, which are a common cause of impaired vision, but thankfully, they are correctable with glasses. You can remember them using the phrase, "my cave, hide of vexed cylinders." Let's begin with myopia, the most common refractive error, also called nearsightedness. In this condition, the eye is too long for the refractive power of the cornea and lens, so light focuses in front of the retina. It is corrected with a concave lens, which is also called a diverging lens. Are you still with me? The next is hyperopia, also known as farsightedness, where the eye is too short for the refractive power of the cornea and lens. As a result, light focuses behind the retina, and this condition is corrected using a convex lens, which is also called a converging lens. Finally, we have astigmatism, which arises from an irregular or asymmetric curvature of the cornea or lens, resulting in different refractive power at different axes. This form of visual distortion is best corrected using a cylindrical lens. Let's talk about disorders of the lens, starting with presbyopia, which is an aging-related impairment in accommodation, meaning difficulty focusing on near objects. Although the pathophysiology is not completely understood, it likely involves a reduction in lens elasticity. As people age, the lens becomes stiffer, and the ability to adjust its shape for near vision diminishes. As a result, patients often require reading glasses or magnifiers to assist with close-up tasks like reading or sewing. Are you following me? Next, we turn to the cataract, which refers to a painless, often bilateral, opacification of the lens. It can lead to glare, a loss of the red reflex, and reduced vision, especially noticeable at night. There are many acquired risk factors that contribute to cataract formation, including increased age, tobacco smoking, alcohol overuse, excessive sunlight exposure, long-term glucocorticoid use, and chronic diseases like diabetes mellitus. It may also result from trauma or infections. On the other hand, congenital cataracts may be due to conditions like classic galactosemia, galactokinase deficiency, chromosomal abnormalities such as trisomies 13, 18, or 21, and torch infections, including rubella. Other genetic syndromes like Marfan, Alport, myotonic dystrophy, and neurofibromatosis type 2 are also implicated. The treatment of cataracts involves surgical replacement of the opaque lens with an artificial intraocular lens. Now listen carefully as we discuss lens dislocation, also known as ectopia lentis, which refers to displacement or malposition of the lens. This can occur after trauma, but may also be a sign of underlying systemic diseases, especially Marfan syndrome and homocystinuria, both of which affect connective tissue and lens stability. In these conditions, the supporting zonular fibers become weakened or stretched, causing the lens to shift from its normal position, leading to distorted vision and possibly other ocular complications. Now let's shift gears and walk through the aqueous humor pathway, which plays a vital role in maintaining intraocular pressure and nourishing the anterior eye structures. Aqueous humor is produced by the non-pigmented epithelium of the ciliary body. This production can be reduced using beta blockers such as timolol, alpha-2 agonists like brimonidine, and carbonic anhydrase inhibitors such as acetazolamide. The fluid flows from the posterior chamber, around the lens, through the pupil, and into the anterior chamber. Are you ready for more? From the anterior chamber, aqueous humor exits the eye via two main outflow pathways. The primary route, called the trabecular outflow, accounts for 90% of drainage. Here, fluid flows through the trabecular meshwork, then into the canal of Schlemm, and finally into the episcleral vasculature. This pathway can be enhanced using muscarinic M3 agonists, such as carbachol and pilocarpine, which contract the ciliary muscle and open the meshwork. The secondary route is the uveoscleral outflow, responsible for the remaining 10% of drainage. It passes through the uvea and sclera, and this route is increased using prostaglandin agonists, like latanoprost and bimatoprost, which remodel the extracellular matrix to facilitate drainage. Let's talk about glaucoma, which refers to an optic neuropathy that causes progressive vision loss, beginning with the peripheral fields and eventually affecting the central vision. It is usually, but not always, accompanied by an increase in intraocular pressure, known as IOP. While the etiology is most often primary, meaning there is no identifiable external cause, it can also be secondary to known conditions, like uveitis or the use of glucocorticoids. On funduscopy, one typically sees optic disc cupping, where the normal optic disc shows thinning of its outer rim, leading to a hollowed appearance. The treatment approach focuses on lowering intraocular pressure, either through medications or surgical methods, to slow or prevent further vision loss. Now let's begin with open-angle glaucoma, which is the most common type in the United States. In this condition, the anterior chamber angle is open, meaning its appearance is anatomically normal. However, there is increased resistance to the drainage of aqueous humor through the trabecular meshwork, which is the main outflow route. Several risk factors contribute to the development of open-angle glaucoma, including increased age, African ancestry, family history, and diabetes mellitus. Most patients are asymptomatic, meaning the disease often goes unnoticed until detected during a routine eye exam. Treatment typically involves medications such as prostaglandin analogs or beta blockers, which help to enhance aqueous outflow or reduce production, respectively. Now listen carefully as we move on to angle closure glaucoma, which involves a narrowed or completely closed anterior chamber angle. This condition is often associated with anatomic abnormalities, such as a forward-displaced lens that rests against the central part of the iris. This leads to impaired aqueous flow through the pupil, creating a pupillary block, which causes pressure buildup in the posterior chamber. As the pressure increases, the peripheral iris is pushed forward, against the cornea, thereby obstructing the drainage pathways. While this form of glaucoma is usually chronic and asymptomatic, it has the potential to become acutely symptomatic, making it a serious medical condition. Are you ready for a critical detail? In acute angle closure glaucoma, there is complete pupillary block, leading to a sudden and complete closure of the angle, with a rapid rise in intraocular pressure. This presents with severe eye pain, conjunctival erythema, sudden vision loss, and halos around lights. Additional symptoms include a headache, a fixed and mid-dilated pupil, and sometimes nausea and vomiting. You should remember this presentation with the phrase, "hurts in a hurry with halos, a headache, and a half-dilated pupil." This is a true ophthalmic emergency that requires immediate intervention to prevent permanent blindness. Importantly, mydriatic agents, which dilate the pupil, are contraindicated in this setting. Management involves medications like beta blockers, alpha-2 agonists, pilocarpine, acetazolamide, and mannitol, all aimed at rapidly lowering the intraocular pressure. Now let's talk about the fucking retinal disorders, beginning with age-related macular degeneration, which is the degeneration of the macula, the central area of the retina, leading to a loss of central vision, known as scotomas. There are two types you should remember. Dry, which is the most common, involves a gradual reduction in vision with subretinal deposits, called drusen. And then there's wet macular degeneration, which leads to a rapid decline in vision, due to bleeding secondary to choroidal neovascularization. An early symptom to watch for is the distortion of straight lines, also called metamorphopsia. Now listen carefully as we move to diabetic retinopathy, which is caused by chronic hyperglycemia, leading to increased permeability and occlusion of retinal vessels. There are two main types: non-proliferative, which is the most common, and features microaneurysms, hemorrhages, cottonwool spots, and hard exudates, with vision loss mainly due to macular edema. And then there is proliferative retinopathy, which involves retinal neovascularization caused by chronic hypoxia. These abnormal new vessels can lead to vitreous hemorrhage and tractional retinal detachment. Are you with me? Let's now discuss hypertensive retinopathy, which results from chronic hypertension causing spasm, sclerosis, and fibrinoid necrosis of retinal vessels. On funduscopy, you may see arteriovenous nicking, microaneurysms, hemorrhages, cottonwool spots, and hard exudates, which can sometimes form a macular star pattern. If papilledema is present, it indicates a hypertensive emergency, and requires immediate lowering of blood pressure to prevent permanent damage. Now let's focus on retinal artery occlusion, which involves blockage of the central or a branch retinal artery, most often due to an embolism, commonly from carotid artery atherosclerosis or sometimes cardiogenic sources, and less commonly due to giant cell arteritis. It presents with acute, painless, monocular vision loss. On funduscopy, the retina appears cloudy, with a characteristic cherry red spot at the fovea, and sometimes you can see retinal emboli, like cholesterol crystals, which appear as small, yellow, refractal deposits in the arterioles. Are you ready for more? Now we come to retinal vein occlusion, where central retinal vein occlusion is typically due to primary thrombosis, while branch retinal vein occlusion is due to secondary thrombosis at arteriovenous crossings, where a sclerotic arteriole compresses the adjacent venule, causing turbulent blood flow. Funduscopy reveals a blood and thunder appearance, with retinal hemorrhage, venous engorgement, and retinal edema in the affected regions. Let's continue with retinal detachment, which involves the separation of the neurosensory retina from the underlying retinal pigment epithelium, resulting in a loss of choroidal blood supply, and leading to hypoxia and degeneration of photoreceptors. There are two types: rhegmatogenous, the most common, caused by retinal tears and often linked to posterior vitreous detachment, especially in older individuals or those with high myopia, and non-rhegmatogenous, which includes tractional or exudative types due to fluid accumulation. Symptoms often start with floaters and light flashes, followed by painless monocular vision loss, described as a dark curtain falling over the eye. On funduscopy, there's opacification, wrinkling of the retina, and changes in vessel direction. It's a surgical emergency. Now listen carefully as we move on to retinitis pigmentosa, a group of inherited dystrophies that cause progressive degeneration of the photoreceptors and the retinal pigment epithelium. It may be associated with abetalipoproteinemia. Early symptoms include night blindness, known as nyctalopia, and peripheral vision loss. On funduscopy, look for the classic triad: optic disc pallor, retinal vessel attenuation, and retinal pigmentation with bone spicule-shaped deposits. Finally, we come to retinopathy of prematurity, which occurs when preterm birth interrupts the normal hypoxic environment in utero, causing relative hyperoxia, especially when supplemental oxygen is used for neonatal respiratory distress syndrome. This reduces VEGF expression, arresting normal retinal vascularization. As the eyes grow, the avascular retina becomes hypoxic, leading to a VEGF surge, and the development of retinal neovascularization, which can result in tractional retinal detachment. It's a common cause of childhood blindness. And now, let's conclude with retinoblastoma, the most common intraocular malignancy in children, which arises from immature retinal cells. It is caused by mutations in both RB1 tumor suppressor genes on chromosome 13, which normally function to impede the G1 to S phase progression of the cell cycle. This condition may occur sporadically or in familial forms, both involving loss of heterozygosity. Clinically, it presents with leukocoria, strabismus, nystagmus, and eye redness. Let's begin with papilledema, which refers to optic disc swelling, usually bilateral, and is caused by increased intracranial pressure, often secondary to mass effect. This condition results from impaired axoplasmic flow in the optic nerve. On funduscopy, you'll see an elevated optic disc with blurred margins, which is a hallmark sign that indicates the seriousness of the underlying process. Now listen carefully as we move to leukochoria, which is the loss, or widening, of the red reflex. It's an important clinical finding, especially in children, where the causes include retinoblastoma, as well as congenital cataract. Are you following me? Let's now talk about uveitis, which is the inflammation of the uvea, and the name used depends on the location of the inflammation within the eye. If it's in the front, it's called anterior uveitis or iritis. If it's in the back, it's called posterior uveitis, which can include choroiditis and or retinitis. Sometimes, the patient may have hypopyon, which is the accumulation of pus in the anterior chamber, or they may present with conjunctival redness. It's often associated with systemic inflammatory conditions, such as sarcoidosis, Behçet syndrome, juvenile idiopathic arthritis, and other HLA-B27 related diseases. Now let's explore the control of pupil size, starting with meiosis, which is pupillary constriction, and it's controlled by the parasympathetic nervous system. The first neuron travels from the Edinger-Westphal nucleus to the ciliary ganglion, via the oculomotor nerve, or cranial nerve 3. The second neuron continues through the short ciliary nerves, reaching the sphincter pupillae muscles, which constrict the pupil. So, the short ciliary nerves function to shorten the pupil diameter. Now let's dive into the pupillary light reflex. Light entering either retina sends a signal through cranial nerve 2, the optic nerve, to the pretectal nuclei in the midbrain. These nuclei then activate bilateral Edinger-Westphal nuclei, causing both pupils to constrict, which is called the direct and consensual reflex. The end result is that shining light into one eye causes both pupils to constrict at the same time. Let's shift gears and examine mydriasis, which is pupillary dilation, and this process is controlled by the sympathetic nervous system. The first neuron begins in the hypothalamus and descends to the ciliospinal center of Budge, located between C8 and T2. The second neuron exits at T1, ascends to the superior cervical ganglion, and travels along the cervical sympathetic chain, passing near the lung apex and the subclavian vessels. The third neuron continues along a plexus on the internal carotid artery, passes through the cavernous sinus, and enters the orbit as the long ciliary nerve, which reaches the pupillary dilator muscles. These sympathetic fibers also innervate the smooth muscle of the eyelids and the sweat glands of the forehead and face. So, the long ciliary nerves function to lengthen the pupil diameter. Now listen carefully, as we conclude with the concept of a relative afferent pupillary defect, also known as a Marcus gun pupil. This condition arises when there are unilateral or asymmetric lesions affecting the afferent limb of the pupillary reflex, such as damage to the retina or the optic nerve. In a normal situation, shining light into either eye should cause both pupils to constrict, through the direct and consensual reflex. But if you swing the light from a normal eye to the affected eye, both pupils dilate instead of constricting, which indicates a defect in afferent input from the damaged side. Now let's begin with Horner syndrome, which results from sympathetic denervation of the face, and presents with a characteristic triad that includes ptosis, which is the slight drooping of the eyelid due to paralysis of the superior tarsal muscle, meiosis, or pupil constriction, and anhidrosis, meaning there is absence of sweating and lack of flushing on the affected side of the face. This syndrome is associated with lesions occurring anywhere along the sympathetic chain, which is why recognizing the site of the lesion is crucial in clinical diagnosis. Are you following me? Let's now discuss the first-order neuron, which runs from the hypothalamus down to the spinal cord, and can be disrupted by a pontine hemorrhage, lateral medullary syndrome, or any spinal cord lesion above T1, including conditions like Brown-Sequard syndrome and late-stage syringomyelia. The second-order neuron passes through the stellate ganglion, and compression here, such as from a Pancoast tumor, can interrupt the sympathetic pathway. Lastly, the third-order neuron travels along the internal carotid artery, and can be damaged by a carotid dissection, which is often painful, and unlike other types, anhidrosis is usually absent in this presentation. Now listen carefully, because here is how the pathway continues, sympathetic fibers from the hypothalamus descend to the lateral horn, then synapse and exit to reach the superior cervical ganglion, where they ascend alongside the internal carotid artery, branch into the ophthalmic artery, and enter the orbit. They innervate the pupillary dilator muscles, eyelid smooth muscle, and facial sweat glands, while some travel along the external carotid artery to reach the forehead sweat glands, and others continue via the long ciliary nerve, completing the intricate sympathetic supply to the head and face. Now let's shift to ocular motility, which refers to the control of extraocular muscles. The lateral rectus, which moves the eye laterally, is innervated by cranial nerve 6. The superior oblique, which depresses and internally rotates the eye, is innervated by cranial nerve 4. All the remaining muscles, including the medial rectus, superior rectus, inferior rectus, and inferior oblique, are innervated by cranial nerve 3. To remember this easily, just think of the mnemonic, LR6, so 4, R3, meaning lateral rectus by 6, superior oblique by 4, and the rest by 3. Are you ready to test the muscles? The arrows in the illustration guide us on how to position the eyes during testing. The rule is, obliques go opposite, so, the left superior oblique and inferior oblique are best tested with the patient looking to the right. And remember the IOU trick, inferior oblique tested looking up. Also, in cases of blowout fracture, which is an orbital floor fracture usually resulting from trauma to the eyeball or infraorbital rim, there is an increased risk of inferior rectus muscle and orbital fat entrapment, which may cause restriction of upward gaze and possibly lead to infraorbital nerve injury. Now let's talk about strabismus, which means eye misalignment, and is often referred to as crossed eyes. The most common type in children is esotropia, where the eye deviates toward the nose. This condition can lead to several complications, including amblyopia, which is the reduced visual acuity due to maldevelopment of the visual cortex, and also diplopia, or double vision, along with adverse psychosocial effects for the child. And finally, you should remember this, amblyopia, also called lazy eye, occurs because of abnormal visual experience early in life, such as from strabismus, and it is typically unilateral. Because the brain suppresses input from the misaligned eye, the visual cortex fails to develop normally for that eye, leading to permanent visual impairment if not corrected early. Now let's talk about cranial nerve 3 damage, which is unique because cranial nerve 3 carries both motor fibers centrally, and parasympathetic fibers peripherally. The most common causes of cranial nerve 3 palsy include ischemia, where motor fibers are more affected than parasympathetic ones, resulting in pupil sparing, and can be seen in conditions like diabetes mellitus, where glucose is converted to sorbitol and vascular perfusion is compromised. Other causes include uncal herniation, which may progress to coma, posterior communicating artery, PCOM, aneurysm, which often presents with sudden onset headache, cavernous sinus thrombosis, which results in ptosis and also involves cranial nerve 4, 5 branch 1/branch 2, and 6, and finally, midbrain stroke, which may cause contralateral hemiplegia. Are you with me? Because now we must differentiate between the motor and parasympathetic functions of cranial nerve 3. The motor output to extraocular muscles is located centrally, and is typically affected in vascular disease, such as diabetes, due to reduced diffusion of oxygen and nutrients to the central part of the nerve. This leads to ptosis and the characteristic down and out gaze. In contrast, the parasympathetic fibers, which are located on the periphery of the nerve, are more vulnerable to compressive lesions, such as a PCOM aneurysm or uncal herniation, and this results in a diminished or absent pupillary light reflex, often producing a blown pupil, which may also occur alongside the down and out gaze. Now listen carefully, and remember this key point: motor fibers are in the middle, while parasympathetic fibers lie on the periphery. So, ischemia spares the pupil, while compression blows the pupil. That's why identifying pupil involvement helps you localize the pathology. Next, let's explore cranial nerve 4 damage, which affects the trochlear nerve. The classic finding here is that the pupil appears higher in the affected eye, and the patient adopts a compensatory head tilt to the contralateral or unaffected side, to counteract the lack of intorsion in the affected eye. The patient often complains that they can't see the floor, especially when going downstairs or reading, because these tasks require intorsion and depression of the eye. Now we'll move cranial nerve 6 damage, which impacts the abducens nerve, and its hallmark is an inability to abduct the affected eye, which means the eye is displaced medially in the primary position of gaze. This leads to horizontal diplopia, and the patient may turn their head toward the affected side to compensate. Now let's review the signs once more for clarity. Cranial nerve 3 motor damage results in ptosis and a down and out gaze, while cranial nerve 3 parasympathetic damage presents with a blown pupil and possibly the same ocular deviation. Cranial nerve 4 palsy shows impaired intorsion, with a compensatory head tilt to the unaffected side. And finally, cranial nerve 6 palsy causes impaired abduction, with the eye turned medially at rest. Let's begin with visual field defects, which can be precisely localized by understanding the path of optic fibers. The ventral optic radiation, known as Meyer's loop, carries information from the lower retina, and it travels through the temporal lobe, looping around the inferior horn of the lateral ventricle. In contrast, the dorsal optic radiation carries input from the superior retina, and it courses through the parietal lobe. These anatomical paths help us determine the cause of specific visual field losses. Are you following me? Because when visual information reaches the primary visual cortex, it arrives upside down and left-right reversed, which is essential for understanding the patterns of field loss. A central scotoma, which affects the macula, is typically seen in macular degeneration. Damage to the optic nerve causes complete anopia of the affected eye, so a left optic nerve lesion leads to left anopia. When the lesion involves the optic chiasm, usually from a pituitary tumor, you get bitemporal hemianopia, which is loss of the outer visual fields from both eyes. Now listen carefully, as we move further down the visual pathway. A lesion in the optic tract causes a homonymous hemianopia, such as right-sided loss in both eyes if the left optic tract is damaged. If the lesion affects Meyer's loop, usually due to a left temporal lesion, the result is a right upper quadrantanopia, also known as pie in the sky. In contrast, damage to the dorsal optic radiation, which travels through the parietal lobe, causes a right lower quadrantanopia, commonly due to a left parietal lesion. Now let's wrap up this part with the visual cortex. A lesion here, especially due to a posterior cerebral artery infarct, results in a right homonymous hemianopia with macular sparing, because the macular area has dual blood supply from the middle cerebral artery. That's why macular vision often remains intact. Now, are you ready to move on to the cavernous sinus, a venous structure located on either side of the pituitary gland? Blood from the eye and superficial cortex drains into the cavernous sinus, then empties into the internal jugular vein. Several key structures pass through it: cranial nerves 3, 4, 5 to 1, 5 to 2, and 6, along with postganglionic sympathetic fibers heading to the orbit. Importantly, the cavernous portion of the internal carotid artery also runs through it. You can remember the contents with eye, tomato, internal carotid, trigeminal nerves, ophthalmic and maxillary, abducens, trochlear, and oculomotor. You should remember this. Cavernous sinus syndrome presents with variable ophthalmoplegia, usually affecting cranial nerve 3 and 6, decreased corneal sensation, features of Horner syndrome, and sometimes reduced maxillary sensation. Causes include pituitary tumor mass effect, carotid cavernous fistula, or cavernous sinus thrombosis, often due to infection. This spread occurs because dural venous sinuses lack valves, allowing retrograde flow of pathogens from the face or orbit into the cranial cavity. Now let's talk about internuclear ophthalmoplegia, a disorder that affects coordinated horizontal eye movement. It occurs due to a lesion in the medial longitudinal fasciculus, or MLF, which is a pair of tracts that interconnect the cranial nerve 6 nucleus with the cranial nerve 3 nucleus. These tracts coordinate both eyes so they can move in the same horizontal direction at the same time. The MLF is highly myelinated, because it needs to transmit signals very rapidly, ensuring the eyes move together seamlessly. Lesions in the MLF can be unilateral or bilateral, with bilateral lesions classically seen in conditions like multiple sclerosis, and sometimes in stroke as well. Now listen carefully. because a lesion in the MLF results in a condition known as internuclear ophthalmoplegia, abbreviated as INO, which is a conjugate horizontal gaze palsy. What happens here is that the communication between cranial nerves 6 and 3 is disrupted. So, when the abducens nucleus on one side activates the ipsilateral lateral rectus, the contralateral oculomotor nucleus fails to stimulate the medial rectus. As a result, the adducting eye does not move, while the abducting eye shows nystagmus, due to overfiring of the abducens nerve trying to compensate. However, convergence is still normal, because it uses a different pathway that does not involve the MLF. Are you following me? This pattern is particularly seen in multiple sclerosis, where demyelination of the MLF interrupts this fast and precise communication. For example, when a person tries to look to the left CN6 nucleus fires, contracting the left lateral rectus, and at the same time, it stimulates the right CN3 nucleus via the right MLF to contract the right medial rectus. But if the right MLF is lesioned, the right eye cannot adduct, and that is the key finding. This mechanism explains the characteristic eye movement seen in internuclear ophthalmoplegia. Now listen closely to this important point. Directional terms like right INO or left INO refer to the eye that is unable to adduct. So, in right INO, the right medial rectus fails to contract, meaning the right eye cannot move inward. Meanwhile, the left eye, trying to abduct, develops nystagmus due to overcompensation from CN6. A helpful memory aid is this: NO equals ipsilateral adduction failure, nystagmus opposite. The combination of adduction failure in one eye, with nystagmus in the other, and normal convergence, is the classic triad that defines this fascinating and localizing syndrome. Now let's reinforce this with the pathway. Imagine voluntary gaze to the left. The left lateral rectus, controlled by the left CN6 nucleus, contracts. That same nucleus sends a signal via the right MLF to stimulate the right CN3 nucleus, which should activate the right medial rectus. But if the right MLF is damaged, the signal never reaches the right oculomotor nucleus, and the right medial rectus doesn't contract. Meanwhile, the left eye moves outward, but it shows nystagmus, trying to correct the asymmetry. This entire movement circuit involves the right frontal eye field, the pons, the abducens nucleus, the PPRF, and the midbrain, making the MLF a critical bridge. Now let's talk about eyelid disorders, and we'll begin with preseptal cellulitis, which is an anterior soft tissue eyelid infection. It typically presents with mild symptoms, including unilateral ocular pain, swelling, and erythema, all of which are present at rest, without affecting the deeper orbital structures. Orbital cellulitis is a far more serious condition. It involves a posterior eyelid infection, affecting the orbital contents, including fat and muscles. Patients often report pain with ocular movement, and diplopia, which means double vision. This infection usually arises secondary to bacterial sinusitis, and the most common pathogens are Staphylococcus aureus, and various streptococci. There is a significant risk of vision loss, cavernous sinus thrombosis, and even intracranial spread, so this condition requires urgent medical attention. Are you with me? Let's move on to blepharitis, which is a common condition involving inflammation of the eyelid margin. Patients may report irritation, redness, and often crusting of the eyelid. Let's talk about the hordeolum, also known as a stye. This is an acute infection of the sebaceous or sweat glands of the eyelid. It presents as a tender, erythematous nodule, usually painful to the touch. Unlike the chalazion, the hordeolum is infectious, and often results from bacterial involvement, especially from Staphylococcus species. Next comes the chalazion, which is a non-infectious granulomatous inflammation, caused by obstruction of either a meibomian gland, which is a modified sebaceous gland, or a Z's gland, which is also sebaceous. It presents as a firm, painless nodule, and while it may resemble a hordeolum initially, it lacks the tenderness and acute infectious signs. And finally, we have the xanthelasma, which appears as a yellowish patch on the medial eyelid. It's not an infection or an inflammation, but rather a lipid-rich deposit, and may be associated with genetic and lifestyle factors, including high cholesterol. Neurology, pharmacology. Let's begin with the narrow-spectrum anticonvulsants, which are primarily used for focal seizures. First, we have phenytoin, which works by blocking sodium channels. Its common adverse effects include sedation, dizziness, diplopia, and gingival hypertrophy, which is preventable with folate supplementation. You should also remember the rash, hirsutism, and drug interactions, especially due to CYP450 induction. Rare but serious adverse effects include Stevens-Johnson syndrome, DRESS, hepatotoxicity, neuropathy, osteoporosis, folate depletion, and teratogenicity. Next in this group is carbamazepine, which also blocks sodium channels. Its common side effects are sedation, dizziness, diplopia, along with vomiting, diarrhea, SIAD, and rash. It also has drug interactions, again due to CYP450 induction. Rare but serious reactions include Stevens-Johnson syndrome, DRESS, hepatotoxicity, agranulocytosis, aplastic anemia, folate depletion, and teratogenicity. Now listen carefully, because we also have the gabapentinoids, which include gabapentin and pregabalin. These work by blocking calcium channels, and the common side effects include sedation, dizziness, ataxia, and weight gain. Are you ready to switch focus? Let's now talk about ethosuximide, which is used specifically for absence seizures. It works by blocking calcium channels, and its common side effects are sedation, dizziness, and vomiting. Though narrow in its use, it remains the preferred agent for typical absence episodes. Now let's talk about the broad-spectrum anticonvulsants, which can treat both focal and generalized seizures. First up is valproate, which acts by blocking sodium and calcium channels, and also inhibits GABA transaminase. Its common side effects are sedation, dizziness, vomiting, weight gain, hair loss, easy bruising, and drug interactions due to CYP450 inhibition. However, serious risks include hepatotoxicity, pancreatitis, and teratogenicity, which is the highest risk among all anticonvulsants. Then comes lamotrigine, which blocks sodium channels. Common effects include sedation, dizziness, and rash. But you must watch for serious reactions like Stevens-Johnson syndrome and DRESS, which can be life-threatening if not recognized early. And now let's move on to levetiracetam, which works by blocking the synaptic vesicle protein 2A, abbreviated as SV2A. It commonly causes sedation, dizziness, and fatigue, but it can also lead to neuropsychiatric effects, including psychosis, although these are rare. Lastly, we have topiramate, which acts by blocking sodium channels and potentiating the GABA-A receptor. It causes sedation, dizziness, mood disturbances like depression, weight loss, and paresthesia. Rare but serious effects include kidney stones and angle closure glaucoma, which require prompt medical attention. Now let's talk about another important broad-spectrum anticonvulsant, the barbiturates, including phenobarbital and pentobarbital. These drugs work by facilitating GABA-A action through increasing the duration of chloride channel opening, which reduces neuron firing. Remember this as barbiturates increase duration. Clinically, they are used as sedatives for anxiety, seizures, and insomnia, and also during alcohol or sedative withdrawal. The adverse effects include respiratory and cardiovascular depression, which can be fatal, CNS depression that is worsened by alcohol use, dependence, and drug interactions, especially due to CYP450 induction. They are contraindicated in porphyria, and treatment of overdose is supportive, with focus on assisting respiration and maintaining blood pressure. Now let's move on to the benzodiazepines, which include diazepam, lorazepam, triazolam, temazepam, oxazepam, midazolam, chlordiazepoxide, and alprazolam. These drugs work by facilitating GABA-A action through increasing the frequency of chloride channel opening, and you can remember this as benzodiazepines increase frequency. They reduce REM sleep, and most of them have long half-lives and active metabolites, except for alprazolam, triazolam, oxazepam, and midazolam, which are short-acting and have a higher addictive potential. Now listen carefully, because the clinical uses of benzodiazepines include anxiety, panic disorder, spasticity, status epilepticus with lorazepam, diazepam, and midazolam, eclampsia, and medically supervised withdrawal, such as in alcohol or delirium tremens, where long-acting chlordiazepoxide and diazepam are preferred. They are also used for night terrors and sleepwalking, as they reduce N3 and REM sleep, for general anesthesia, with amnesia and muscle relaxation, and as hypnotics for insomnia. Importantly, lorazepam, oxazepam, and temazepam can be used for those with liver disease who drink a lot, due to their minimal first-pass metabolism. You should remember that adverse effects of benzodiazepines include dependence, additive CNS depression effects with alcohol and barbiturates, since all of them bind the GABA-A receptor. However, they have less risk of respiratory depression and coma than barbiturates. Overdose is treated with flumazenil, which is a competitive antagonist at the GABA benzodiazepine receptor, but this can precipitate seizures by causing acute benzodiazepine withdrawal. Now let's talk about insomnia therapy, beginning with non-benzodiazepine hypnotics, including zolpidem, Zalplan, and isopoquone. These agents act via the BZ1 subtype of the GABA receptor. Adverse effects include ataxia, headaches, and confusion. They cause only modest day-after psychomotor depression, and few amnestic effects, compared to older sedative hypnotics. You should know that these ZZZs put you to sleep, with short duration due to rapid metabolism by liver enzymes, and their effects are reversed by flumazenil. They have reduced dependency risk and less sleep cycle disturbance compared to benzodiazepine hypnotics. Next is suvorexant, an orexin, also known as hypocretin receptor antagonist. It may cause CNS depression with somnolence, headache, and abnormal sleep-related activities. It is contraindicated in narcolepsy, and with strong CYP3A4 inhibitors. It is not recommended in patients with liver disease, but it has limited risk of dependency, making it a safer option for some individuals. Lastly, we have ramelteon, a melatonin receptor agonist, which binds MT1 and MT2 in the suprachiasmatic nucleus. Its side effects are usually mild and include dizziness, nausea, fatigue, and headache. Importantly, there is no known risk of dependency, making it a preferred option for long-term sleep regulation. Are you still with me? Because now let's wrap up this section with the triptans, such as sumatriptan. These drugs are 5-HT1B/1D agonists, which work by inhibiting trigeminal nerve activation, preventing vasoactive peptide release, and inducing vasoconstriction. They are used for acute migraine attacks and cluster headaches, and the mnemonic reminder is that a sumo wrestler trips and falls on their head. You should remember, adverse effects of triptans include coronary vasospasm, which means they are contraindicated in patients with coronary artery disease or vasospastic angina. Other effects include mild paresthesia, and serotonin syndrome, especially when used with other 5-HT agonists. Now listen carefully, when it comes to Parkinson disease therapy, the most effective treatments include non-ergot dopamine agonists for younger patients, and levodopa with carbidopa for older patients. In advanced disease, deep brain stimulation of the subthalamic nucleus, or globus pallidus internus, provides additional benefit. The general strategy involves different classes of agents, and each targets specific steps in the dopamine pathway to help manage symptoms. First, let's talk about dopamine agonists. The preferred options are the non-ergot agents, such as pramipexole and ropinirole. Their toxicities include nausea, impulse control disorders like gambling, postural hypotension, hallucinations, confusion, sleepiness, and edema. The older ergot agent, bromocriptine, is now rarely used because of its higher toxicity profile. These agents directly stimulate dopamine receptors, mimicking the effects of dopamine in the brain. Let's move to agents that increase dopamine availability, beginning with amantadine, which increases dopamine release and reduces dopamine reuptake. It is mainly used to reduce levodopa-induced dyskinesias, and its toxicities include peripheral edema, livedo reticularis, and ataxia. By modulating dopamine levels, amantadine helps smooth out motor fluctuations without altering levodopa metabolism directly. To increase L-dopa availability, certain agents are used to prevent peripheral, or pre-blood-brain barrier, degradation of L-DOPA. This results in more L-DOPA entering the central nervous system, where it can be converted into dopamine. One such combination is levodopa with carbidopa. Carbidopa blocks peripheral conversion of L-DOPA to dopamine by inhibiting dopa decarboxylase, and it also reduces adverse effects like nausea and vomiting, which result from peripheral dopamine buildup. Also under this category are entacapone and tolcapone, which prevent peripheral L-DOPA degradation to 3,0-methyldopa, or 3-OMD, by inhibiting the enzyme COMT. These are used in conjunction with levodopa to improve its efficacy. Entacapone works only peripherally, while tolcapone has both peripheral and central actions, making it more potent, but also requiring careful monitoring. The next group helps prevent dopamine breakdown inside the brain. These agents work centrally, that is, post-blood-brain barrier, to inhibit enzymes that degrade dopamine. Selegiline and razagiline block the conversion of dopamine to dopac, through selective inhibition of MAOB, an enzyme found more in the brain than in the periphery. These drugs are especially helpful for patients experiencing cyclic fluctuations in levodopa efficacy, often described as the on-off phenomenon. In addition, tolcapone, which, as mentioned earlier, crosses the blood-brain barrier, also blocks the conversion of dopamine to 3-methoxytyramine, or 3 metric tons, in the brain by inhibiting central COMT. You can remember this by saying tolcapone pays the toll and can cross the BBB. Now let's finish by talking about agents that curb excess cholinergic activity, which contributes to Parkinson's symptoms like tremor and rigidity. These include benztropine and trihexyphenidyl, which are antimuscarinic agents. They are useful in improving tremor and rigidity, but they have little effect on bradykinesia. A helpful mnemonic is "Try parking my Mercedes-Benz," reminding you of trihexyphenidyl and benztropine in Parkinson's disease. Carbidopa/levodopa works by increasing dopamine in the brain. Unlike dopamine itself, L-DOPA can cross the blood-brain barrier, and once inside the central nervous system, it is converted by dopa decarboxylase into dopamine. To enhance this process, carbidopa, which is a peripheral dopa decarboxylase inhibitor that cannot cross the BBB, is given together with L-DOPA. This combination serves to increase the bioavailability of L-DOPA in the brain, while also helping to limit peripheral adverse effects like nausea and hypotension. The clinical use of this combination is for Parkinson's disease, where dopamine levels are significantly depleted. However, there are adverse effects to consider, including nausea, hallucinations, and postural hypotension. And with the progression of the disease, L-DOPA treatment can lead to the on-off phenomenon, where the patient experiences improved mobility during on periods, followed by impaired motor function during off periods, either due to poor response to L-DOPA or the wearing off of the medication. Talking about neurodegenerative disease therapy, beginning with Alzheimer's disease, where we use donepezil, rivastigmine, and galantamine. These are all acetylcholinesterase inhibitors, and they are considered the first-line treatment. The adverse effects include nausea, dizziness, and insomnia, and they are contraindicated in patients with cardiac conduction abnormalities. You can remember this with the phrase, "Dona Riva forgot the gala," to recall donepezil, rivastigmine, and galantamine. Are you ready to move on? For moderate to advanced Alzheimer dementia, memantine is used. It is an NMDA receptor antagonist, which helps prevent excitotoxicity, a process that is mediated by calcium ions. Its adverse effects include dizziness, confusion, and hallucinations. Now listen closely. In the case of amyotrophic lateral sclerosis, or ALS, the agent used is riluzole. It works by reducing neuron glutamate excitotoxicity, thereby increasing survival. An easy way to remember this is by saying, treat Lou Gehrig disease with riluzole, linking the name of the disease with the medication itself. Finally, for Huntington disease, the medications deutetrabenazine and tetrabenazine are used. These drugs inhibit the vesicular monoamine transporter, or VMAT, which reduces dopamine vesicle packaging and release. These agents may also be used to manage Huntington chorea and tardive dyskinesia. Let's talk about local anesthetics, which are divided into two main groups. Esters include benzocaine, chloroprocaine, cocaine, and tetracaine, while amides include bupivacaine, lidocaine, mepivacaine, prilocaine, and ropivacaine. A helpful tip to distinguish them is that amides have two I's in their names, unlike esters. Now listen carefully, these local anesthetics work by blocking neurotransmission, and they do this by binding to voltage-gated sodium channels, specifically to the inner portion of the channel along nerve fibers. You should remember this, the 3 degrees amine local anesthetics penetrate the membrane in an uncharged form, and once inside, they bind to ion channels as a charged form. They are most effective in rapidly firing neurons, and often, they are given with vasoconstrictors like epinephrine, to prolong their effect by reducing systemic absorption. However, in infected or acidic tissue, the alkaline anesthetics become charged, which means they cannot penetrate the membrane effectively, and so, more anesthetic is needed. The order of sensory loss follows this pattern: first pain, then temperature, followed by touch, and finally pressure. Now let's go over the clinical uses, which include minor surgical procedures and spinal anesthesia, and remember, if a patient is allergic to esters, then amides should be used. But be cautious, because the adverse effects can include central nervous system excitation, severe cardiovascular toxicity, especially with bupivacaine, hypertension or hypotension, arrhythmias with cocaine, and methemoglobinemia, which can occur with benzocaine and prilocaine. Are you ready for more? Let's move on to general anesthetics, which are CNS drugs that must be either lipid-soluble to cross the blood-brain barrier, or actively transported. Drugs with lower solubility in blood, such as nitrous oxide, N2O, provide rapid induction and recovery times, while those with higher lipid solubility, like isoflurane, have greater potency. This brings us to the concept of MAC, which stands for minimum alveolar concentration, the amount of inhaled anesthetic required to prevent 50% of subjects from moving in response to a noxious stimulus like a skin incision, and keep in mind, potency is inversely proportional to MAC, or 1 divided by MAC. Now listen carefully, among the inhaled anesthetics, sevoflurane, desflurane, and isoflurane have a mechanism that is still unknown, but they share several effects. These include respiratory depression, reduced cough reflex, myocardial depression, decreased blood pressure, increased cerebral blood flow, which raises intracranial pressure, and reduced metabolic rate. They also lead to decreased skeletal and smooth muscle tone, postoperative nausea and vomiting, and in some cases, malignant hyperthermia. Nitrous oxide, although it has very low potency, can cause diffusion into and expansion of gas-filled cavities, such as a pneumothorax. Now let's shift gears to intravenous anesthetics. First, we have propofol, which potentiates the GABA receptor, and also inhibits the NMDA receptor. It causes respiratory depression and reduced blood pressure, and it is the most commonly used intravenous agent for induction of anesthesia. Next is etomidate, which also potentiates the GABA receptor, and it is hemodynamically neutral, but it can lead to acute adrenal insufficiency and postoperative nausea and vomiting. Finally, we have ketamine, which inhibits the NMDA receptor, and it acts as a sympathomimetic, raising blood pressure, heart rate, and cerebral blood flow, while also causing bronchodilation. However, it can also cause psychotomimetic effects, including hallucinations and vivid dreams. Now let's talk about neuromuscular blocking drugs, which are used to induce muscle paralysis during surgery or mechanical ventilation, and are selective for NM-nicotinic receptors located at the neuromuscular junction, but not for the autonomic NN receptors. There are 2 main types, depolarizing and non-depolarizing neuromuscular blockers, and each has a distinct mechanism and reversal approach. Let's begin with the depolarizing neuromuscular blocking drugs, where the key agent is succinylcholine, a strong NM-nicotinic receptor agonist. It works by producing sustained depolarization, which prevents muscle contraction. Now listen carefully, the reversal of blockade depends on the phase. In phase 1, which involves prolonged depolarization, there is no antidote, and in fact, the block is potentiated by cholinesterase inhibitors. In phase 2, which is characterized by repolarization, but with receptors that are desensitized, reversal may be attempted using cholinesterase inhibitors. But be aware of the complications, which include hypercalcemia, hyperkalemia, and malignant hyperthermia, and note that there is also an increased risk of prolonged muscle paralysis in patients who have pseudocholinesterase deficiency. Now let's continue with the non-depolarizing neuromuscular blocking drugs, which include atracurium, cisatracurium, pancuronium, rocuronium, and vecuronium. These agents act as competitive N-nicotinic receptor antagonists. The reversal of these drugs is typically done using sugammadex or cholinesterase inhibitors like neostigmine, and don't forget, anticholinergic agents such as atropine or glycopyrrolate must be given alongside the cholinesterase inhibitors, to prevent muscarinic side effects such as bradycardia. Are you still with me? Now listen carefully as we turn to a critical condition known as malignant hyperthermia, a rare but life-threatening hypermetabolic disorder. It is triggered by the administration of potent inhaled anesthetics like sevoflurane, desflurane, or isoflurane, or by the use of succinylcholine, especially in susceptible individuals. This susceptibility results from de novo or inherited mutations, passed in an autosomal dominant fashion, affecting either the ryanodine receptor, RYR1, or the dihydropyridine receptor, DHPR. These mutations lead to increased calcium release from the sarcoplasmic reticulum, which causes sustained muscle contraction, and results in hypercapnia, tachycardia, masseter and generalized muscle rigidity, rhabdomyolysis, and hyperthermia. Are you following me? The treatment for this dangerous condition is dantrolene, which acts as a ryanodine receptor antagonist, effectively reducing calcium release and helping to reverse the hypermetabolic state. The skeletal muscle relaxants, each with a distinct mechanism and clinical application. First, we have baclofen, which is a GABA receptor agonist that acts in the spinal cord. It is used for muscle spasticity, dystonia, and multiple sclerosis, and since it acts on the back, specifically the spinal cord, you should remember that it may cause sedation. The cyclobenzaprine, which acts within the CNS, primarily at the brainstem, and is used for muscle spasms. It is a centrally acting agent, and is structurally related to tricyclic antidepressants, TCAs. So be cautious, because it may cause anticholinergic adverse effects, including sedation. Are you following me? Now let's continue with dantrolene, which prevents the release of calcium from the sarcoplasmic reticulum of skeletal muscle by inhibiting the ryanodine receptor. Dantrolene is used in cases of malignant hyperthermia, which is caused by the toxicity of inhaled anesthetics or succinylcholine, and in neuroleptic malignant syndrome, which results from antipsychotic toxicity. It's important to note that dantrolene acts directly on muscle, unlike others that work centrally. Finally, we have tizanidine, which is an alpha-2 agonist that acts centrally, and is used to manage muscle spasticity, especially in multiple sclerosis, ALS, and cerebral palsy. Let's shift gears and discuss opioid analgesics, which act as agonists at opioid receptors, mu for beta-endorphin, delta for enkephalin, and kappa for dynorphin. They modulate synaptic transmission by closing presynaptic calcium channels and opening postsynaptic potassium channels, which reduces synaptic transmission. They also inhibit the release of several neurotransmitters including acetylcholine, norepinephrine, serotonin, glutamate, and substance P. In terms of efficacy, full agonists include morphine, meperidine, methadone, codeine, and fentanyl. Codeine is a prodrug activated by CYP2D6. Partial agonists include buprenorphine, while mixed agonists/antagonists include butorphanol and nalbuphine, and antagonists include naloxone, naltrexone, and methylnaltrexone. Now listen carefully, these drugs are used for moderate to severe or refractory pain, for diarrhea using loperamide or diphenoxylate, for acute pulmonary edema, and also in maintenance programs for opioid use disorder, using methadone or buprenorphine with naloxone. They are also used to manage neonatal abstinence syndrome, using methadone or morphine. You should remember this: adverse effects include nausea, vomiting, pruritus due to histamine release, opioid use disorder, respiratory depression, constipation, sphincter of Oddi spasm, and meiosis, except for meperidine, which causes mydriasis. There is additive CNS depression when combined with other drugs. Importantly, tolerance does not develop to meiosis and constipation. Toxicity is treated with naloxone, and relapse prevention is achieved using naltrexone, after detoxification. Now let's wrap up with tramadol, which is a very weak opioid agonist, but also inhibits the reuptake of norepinephrine and serotonin. It is used for chronic pain, but note that it has adverse effects similar to opioids. It also lowers the seizure threshold, and may cause serotonin syndrome. Now listen carefully, let's begin with butorphanol and nalbuphine, which are mu-opioid receptor partial agonists and kappa-opioid receptor full agonists. These mixed opioid agonist-antagonist drugs are used for analgesia in severe pain, such as labor pain, and are known to cause less respiratory depression than full opioid agonists. But here's something important: if a patient is already taking a full opioid agonist, these drugs can trigger opioid withdrawal symptoms, because of competition for the same opioid receptors. You should remember, these agents are not easily reversed with naloxone, so special care must be taken during use. Are you following me? Good, now let's talk about capsaicin, which is naturally found in hot peppers, and works by excessively stimulating and desensitizing nociceptive fibers, which leads to a reduced release of substance P, and this ultimately decreases the sensation of pain. Capsaicin is used for musculoskeletal and neuropathic pain, and it's helpful especially in chronic conditions where nerve irritation persists. It's a topical agent, but powerful in its action, and should be used regularly to achieve full effectiveness. Now let's shift our focus to something entirely different: glaucoma therapy, which aims to reduce intraocular pressure by lowering aqueous humor volume, either by inhibiting its synthesis or secretion, or by increasing its drainage. There's a helpful phrase to remember this concept: beta-alpha D. Humor may not be politically correct, where beta stands for beta blockers, alpha for alpha agonists, and D for diuretics. Now listen closely, because the treatment classes vary in both mechanism and adverse effects. We begin with beta blockers, like timolol, betaxolol, and cartiolol, which work by reducing aqueous humor synthesis without causing any pupillary or vision changes. Then we have alpha agonists, such as epinephrine for alpha-1, and aproclonidine or brimonidine for alpha-2 receptors. Epinephrine acts via vasoconstriction, reducing aqueous humor synthesis, while aproclonidine and brimonidine do the same but also increase outflow through the uveoscleral pathway. However, alpha-1 agonists can cause mydriasis, so they should not be used in closed-angle glaucoma. They may also cause blurry vision, ocular hyperemia, foreign body sensation, ocular allergic reactions, and pruritus. Now let's continue with diuretics, particularly acetazolamide, which lowers intraocular pressure by inhibiting carbonic anhydrase, thereby reducing aqueous humor synthesis. These also do not affect vision or pupil size, making them useful in specific clinical settings. Then we come to the prostaglandins, such as bimatoprost and latanoprost, which are analogues of PGF2-alpha, and increase aqueous humor outflow by reducing resistance in the uveoscleral pathway. But keep in mind, they may darken the color of the iris and cause eyelash growth, both of which are notable cosmetic effects. Finally, we arrive at the cholinomimetics, acting on M3 receptors, with direct agents like pilocarpine and carbachol, and indirect agents such as physostigmine and ecothiopate. These work by contracting the ciliary muscle, thereby opening the trabecular meshwork, and increasing outflow of aqueous humor. Pilocarpine is especially effective in acute angle closure glaucoma, as it rapidly opens the meshwork to the canal of Schlemm. But remember this: they cause meiosis, which is contraction of the pupillary sphincter, and cyclospasm, which is contraction of the ciliary muscle. That is it. Thanks for listening.